ARBs and a diuretic. ठीक है. Sometimes non-dihydropyridine calcium channel blockers or chlorine can also be used. Beta blockers useful नहीं है, and nitrates are useful for the relief of ischemic pains. Now the first drug which we use in hypertension with chronic stable angina is a beta blocker. The first line therapeutic agent. In this also, it is preferable to use cardioselective beta blockers which do not have an intrinsic sympathetomimetic activity. Now, this word intrinsic sympathetomimetic activity is a very difficult word to understand. I'll just speak just 2 or 4 lines about this. देखिए, बेटा ब्लॉकर्स 2 किस्म के रहते हैं. एक रहता है नॉन सेलेक्टिव कार्डियो, एक रहता है कार्डियो सेलेक्टिव, एक दूसरा रहता है नॉन कार्डियक सेलेक्टिव. कार्डियो सेलेक्टिव में भी selective beta blockers, there are 2 types. One is with intrinsic sympathomimetic activity and the others are without intrinsic sympathomimetic activities. Those without intrinsic sympathomimetic activities, मतलब atenolol, metoprolol, bisoprolol, ये drugs are which do not have intrinsic sympathomimetic activity. Other drugs like, for example, carvedilol, pindolol, ismalol, libitalol, these have intrinsic sympathomimetic activity. So you have to use a drug which is cardioselective. Second, it does not have an intrinsic sympathomimetic activity. For example, etanol, beta blocker, like bisoprolol and metoprolol. ये हुई पहली बात. So beta blockers, they also they decrease the ischemia, they also decrease the angina, they decrease your heart rate. And this causes decrease in the oxygen consumption. And when they decrease their heart rate, this also allows for the coronary blood flow to increase. And to a very little extent, they also inhibit the renin, release of renin from the juxtaglomerular apparatus. But unfortunately, the thing is that they are also contraindicated if there's hypertension or the patient has SO dysfunction in a very severe decompensated heart failure. And especially those patients with a very severe bronchospastic disease. In fact, the thing is that nowadays, even in patients with COPD or those with severe bronchospasm also, we do use a little bit of beta blockers. For example, a very cardioselective like bisoprolol, which don't have intrinsic sympathomimetic activity. As Ehsan sir had just said, कि आपको डायबिटिक पेशेंट्स में स्पेशली दोज जिनका क्या कहते हैं इंसुलिन दे आर वेरी हाई डोजेस ऑफ इंसुलिन, avoid beta blocker because it usually masks the symptom of hypoglycemia. But the thing is that frankly speaking, I have not seen any patient who I've given a beta blocker to and the symptoms of hypoglycemia have been masked. So, but still, F1 coronary artery disease and a diabetic patient, I will say that start with a very low dose because these are the first line of medication. You would want to start a beta blocker. After beta blocker comes calcium channel blockers. In chronic stable heart disease, ischemic heart disease, stable angina, which we say. Here we have 2 types of calcium channel blockers. One are dihydropyridines and the second are non-dihydropyridines. Dihydropyridines matlab aapke nicardipine and non-dihydropyridine agents are also not preferred in patients with stable heart failure initially, and especially the short-acting dihydropyridine agents are not preferred in acute MI, pulmonary edema, and left ventricular dysfunction. This last line I would like to talk a bit more about it. Whenever we have a patient, suppose his LV function is around 30%, 25 or 30%. And a lot of times he has bradycardia, severe bradycardia. You can see a heart rate around 45, 50, like that. And or in patient pulmonary edema. At that time, there's very much doubt whether we can start calcium channel blockers or not. But my experience or what we've practiced, we found that starting with very low dose of long-acting calcium channel blockers like amlodipine can help in such patients also. Now, management of hypertension and coronary artery disease, that is chronic stable angina with ACE inhibitors and ARBs, they have been shown in a lot of trials to reduce the left ventricular hypertrophy, the remodeling, and the blood pressure, and lot of studies. 2 particular studies हैं, एक तो यूरोपीय स्टडी है और दूसरा होप ट्रायल है. they have definitely showed that there is 20% reduction in the risk of sudden cardiac death. 20% reduction is very good amount. मतलब अगर आपने 80% 100% patients में दिया है तो 20% patients में there is a definite improvement, that there is reduction in mortality. And जो patients में AC inhibitors are advised not to be given, जैसे जिनको renal artery stenosis है या जिनको angioedema हो चुका है या जिनको allergic reaction है AC inhibitor से, तो ARBs can be used in their place. Chronic stable angina, use of thiazides and nitrites. Thiazide diuretics are highly effective in lowering the blood pressure, and they even prevent cerebrovascular events. This has been found in a number of trials like the MRC and the SHEP trial. Nitrates, long-acting nitrates are better to be used compared to short-acting ones. They help in controlling or alleviating chest pain, and they are also used in adjunct with beta blockers and calcium channel blockers also. And hypertension does not impact the use of long-acting nitrates for the prevention of angina, or of sublingual nitrate for the relief of anginal attacks. Now, the limitation of thiazide diuretics is that thiazide diuretics should be used very cautious in patients with chronic kidney disease, ultimately those who have a low GFR. They are also not recommended in diabetic patients on oral hypoglycemics, as they increase the resistance of insulin. And in such patients, if you do want to start with the diuretics, and if you want a fast action, use the metolazone, or in the previous time, indapamide reduced. Nowadays, the use of indapamide has come down drastically. And if you want a very, very potent and a very a loop diuretic with a very good bioavailability, it is torsemide. So the cautions which we've seen in patients with symptomatic coronary artery disease and hypertension, the combination of beta blocker and a non-dihydropyridine calcium channel blockers should be used with cautions. Simples, एक बीटा ब्लॉकर को एक दिलथियाजम के साथ देना नहीं है, या एक मेट्रोप्रोलॉल को वेरापेमल के साथ देना नहीं है, because significant bradyarrhythmias happen and it precipitates heart failure. And when you use such a combination, it's very difficult to get the heart rate back to normal. And those patients with coronary artery disease, the BP should be lowered very slowly, and caution should be advised when inducing fall in the BP. Here, I would like to tell something very important. See, the management of blood pressure in a neurology patient, the management of blood pressure in a nephrology patient, and the management of blood pressure in a cardiology patient थोड़ा सा different रहता है. See, the most important thing is that those patients in cardiology patients who have low blood pressure, around 50% of them also have a LV dysfunction. Okay, as it is, their blood pressure is a bit on the lower side. For any organ, whenever you're starting the treatment for blood pressure, always look at the mean pressure also, because a lot of times what happens is that you try to bring the blood pressure to a lower level and the auto-regulation mechanism fails, and that itself leads to complications. It's not like statin therapy, the lower the better. The hypertension management has a upper limit as well as a lower limit. Try not to go down the lower limit, because if you try to go as low as possible, then you're going to have a lot of problems. Then organ damage is definitely going to start in. So try to maintain, even if you're going at a lower range, try to maintain a mean pressure of at least 7 to 100. That's the most important thing. So if you're having a systolic blood pressure of 100, see that your diastolic blood pressure doesn't go more less than 50, 40, 55 or 60. Try to keep a mean pressure of around 7 to 100. Now, my most important topic, or my favorite topic, hypertension and acute coronary syndromes. ठीक है. Acute coronary syndromes में आपको unstable angina मिलेगा, आपको NSTEMI मिलेगा, and आपको ST elevation myocardial infarction मिलेगा. Right. Here, arterial hypertension is one of the major leading causes of atherogenesis. Number one. Number two, hypertension से वो जो vulnerable plaque है, the plaque which ruptures, it is one of the most important cause for causing instability of the plaque. And we have seen that 50% पेशेंट जो एनस्टेमिक के साथ प्रेजेंट होते हैं उनमें हाइपरटेंशन रहता है, एंड जो पेशेंट में एमआई रहता है और उनमें हाइपरटेंशन की हिस्ट्री भी है, उनके मॉर्टेलिटी भी ज़्यादा रहती है. So it's a double-edged sword. And elderly women, elderly individuals, Asian and Africans, and those with more comorbidities are more likely to be affected with mortality in a patient who has MI. Coming to management of hypertensive patient with unstable angina and STEMI, initial management, this आप सबको मालूम है, it's a very basic thing. Get a good bed rest, continue ECG monitoring, start oxygen therapy if you're suspecting the patient is in failure, start morphine if the patient अगर pain भी है, and sedation if necessary अगर patient is very restless. Pharmacological therapies includes nitroglycerin, beta blockers, calcium channel blockers, AC inhibitors, and aspirins. Right? Nitroglycerin is the cornerstone of treatment. अब मैं nitroglycerin का ऐसा होता है कि patient comes to you with MI having hypertension, start NTG. NTG will cause a lot of will help in a lot of things. सबसे पहले it increases the coronary blood flow. Second, it stabilizes the myocardium also. Third, it stabilizes your plaque also. When you're starting NTG, I'm going to make very subtle points. आप जब NTG start कर रहे हो, try to maintain the blood pressure less than 130, 140 systolic, and if your diastolic blood pressure goes in less than 70, try to stop the this thing. Second thing, NTG से coronary flow improve होता है. Even post plasty, हम लोग जब stent डाल देते हैं, when we put a stent, the flow from the coronary artery also increases with the help of NTG. Coming to beta blockers, if possible, the first minute the patient comes to the hospital and he does not have any contraindication for starting a beta blocker, start a beta blocker. It always in combination with nitrate has a beneficial effect. हम लोगों को we have to use a cardioselective beta blocker. मैंने जैसे आपको बताया है, cardioselective non intrinsic sympathomimetic beta blocker जैसे metoprolol or bisoprolol should be used. शॉर्ट एक्टिंग बीटा ब्लॉकर्स यूजुअली इंडिया में मिलते नहीं हैं. जो शॉर्ट एक्टिंग बीटा ब्लॉकर्स जो पहले मिलते थे आईवी फॉर्म्स, वो भी उनका भी मार्केट में दी व्हाट डू यू से द सेल्स इज वेरी लेस. सो द बेस्ट थिंग इज ट्राई टू यूज a beta blocker as early as possible. The things which stop us from using a beta blocker is if the patient is in severe heart failure, वो आपके पास आता है एक pulmonary edema के स्टेट में, उसका saturation 30, 40, 70, 80 है, he is in failure, hypertension में है, CHB में है, and patient is a chronic smoker, पूरा एक barrel shaped chest है. So in these conditions, be very careful. I mean, hold on to your beta blocker. लेकिन apart from these conditions, use a beta blocker as much as possible. Second, calcium channel blockers. अब देखिए calcium channel blockers MI में usually a lot of physicians and a lot of cardiologists hesitate to start it. There are two types of calcium blockers. एक तो मैं बताया आपको amlodipine की फैमिली है, दूसरे verapamil and diltiazem है. Verapamil and diltiazem बहुत rarely use होता है, especially in those conditions जहाँ पे आप beta blockers दे नहीं पाते हैं. लेकिन verapamil और diltiazem should be very cautiously used. In fact, should not be used, I would say, if you have LV dysfunction. Anything less than 40% of LV function should avoid using a verapamil or diltiazem. But if the patient has MI and the blood pressure is very highly raised and you're not able to give a beta blocker, you have started with an AC inhibitor, still the pressures are not coming down. In those conditions, you can start using a long-acting dihydropyridine calcium channel blockers. Like, for example, at our place, we use amlodipine. Second comes to AC inhibitors and ARBs. AC inhibitors and ARBs, I personally prefer using an AC inhibitors because most of the studies which have been done are with perindopril and ramipril. So I prefer using a ramipril rather than more expensive drugs. So ramipril I usually use when hypertension persists and the patient diabetic भी है, साथ में साथ LV dysfunction भी है आपने. Aspirin, all of you know, aspirin, the sooner the possible. अगर you can crush the aspirin, you can give it, sabit, or you can crush it and give it. Crushing it increases the absorption, helps to achieve the blood levels as soon as possible, and gives a better result. The recommendation, as I've just mentioned, beta blocker को जितना जल्दी use कर सकते हैं, start using it. Use a beta blocker, cardioselective beta blockers or IV if available. Use an IV as soon as possible. Just see for the side effects or just see for the contraindications. Second, those patients who are not able to use a beta blocker. So, hello? Yeah. So those patients who are not able to use a beta blocker, try a calcium channel blocker. And every patient should be at least started with a dose of AC, ARBs inhibitors. One small point I would like to mention over here, the use of ARNI. The salcubitril valsartan combination. till now, unfortunately, there are no proper studies which show that using ARNIs in acute setting of MI. So as soon as a week passes of a patient having MI, you can definitely start using an ARNI in those patients. The trials which have shown the beneficial effect of beta blockers is TIMI study, then ISIS study. These are the style. AC inhibitors also should be started as soon as possible. Preferably, they say within 24 hours. And if they're intolerant to AC inhibitors, go with ARBs. Aldosterone antagonists are always added in a patients with MI or stem with basically ACS, acute coronary syndromes, except if they have a potassium level more than 2.5 or the creatinine is definitely more than 2.5. I mean, potassium level more than 5 and a creatinine level more than 2.5. And otherwise, a diuretic with an aldosterone antagonist is always a good drug of choice. Calcium channel blockers, like non-dihydropiridine calcium channel blockers, may be used for the treatment of patients with supraventricular tachycardia if they get. And long-acting non-dihydropiridine calcium channel blockers are used for the control of blood pressure. Yes. I'd like to stop my talk over here. I've tried to keep it as basic as possible. And if anyone has any doubt whatsoever, they can ask me over here or they can directly contact me also. I'd be happy to revert back. Thank you very much.
Thank you very much, sir, for your very much practical inputs into the subject. Definitely, the way you have said this should be used and this should be not is very much practically what we do understand. Thank you, sir.
Right. Thank you very much. Thank you.
You can stop sharing your screen. Yeah. Okay. Okay, sir. So you can. Yeah. Okay. So it is the time for our chief guest, uh, Dr. Abdul Majid, sir, to do his presentation. Sir needs no introduction, but just formally, I would like to tell you all that he did his MBBS and MD in medicine from GMCH Aurangabad. Sir has done his DM in neurology from KEM Hospital, Mumbai. Sir is a practicing and Alhamdulillah highly successful consultant neurologist since 24 years in the city and around the city in the region, I would say. He is a co-owner and director of Apex Super Specialty Hospital. He is a member of American Academy of Neurology, World Stroke Association. His areas of interest is stroke and functional neurology, and I welcome him to the webinar that we are conducting, and I request him to kindly share his screen and start his presentation. All to you, sir.
Yeah. Good afternoon, everyone. I know it's late. I hope I'm audible to everyone.
Yes.
Yeah. So we are running late because of some technical issues. No worries about that. But I'm worried people are getting hypoglycemic, and so I wonder, should I make my topic little more practical? And I've prepared slides which are little less crowded and has more practical inputs. Yeah, here is an overview. Hypertension We have been hearing this since morning, and we'll discuss how hypertension causes brain damage. There are some misconceptions about hypertension, and I'll be giving some practical tips about managing hypertension out of my 24 years of clinical practice. And we'll talk a little about pathophysiology of brain damage caused by hypertension, and then what is stroke and its types, manifestations of effects of hypertension on brain, some illustrative cases, and then treatment goals and take-home messages. That will be overview. So coming to misconceptions, people ask so many questions in day-to-day practice. Mildly elevated BP is okay, doesn't need treatment sometimes, but uh, in these cases, I think where the people are not convinced, ambulatory BP monitoring is important in few select cases. That once started, lifelong treatment is needed. So that is a very common misconception among people. एक बार शुरू हो गई तो फिर जिंदगी भर गोली लेना पड़ा. I take the medicine on alternate days or once in 3 days, and I'm okay. I don't have any symptoms. So I think understanding. Then some people will say, I sense the elevated BP and take the BP medicine SOS. मुझे समझ जाता है कि मेरा ब्लड प्रेशर बढ़ रहा है, तब मैं मेडिसिन लेता हूँ. Few people are really worried about side effects of allopathic medicines, as we all know. And some people will say, my GP said your BP is normal now, so you can stop the medicine. The person is taking medicine, that's why his blood pressure is not normal now, but he wants to stop the medicine. And few people will say, I don't have any symptoms, so why should I take the medicine? Because as we know, hypertension is a silent killer. So sometimes there may be absolutely no symptoms and signs whatsoever, except for raised blood pressure. What are the practical tips? Learn to record BP properly. I think that should be learned. Though we are becoming senior day by day, we should learn to take it properly. We should teach our junior doctors and residents to record the BP properly. That has been talked about since morning. Don't rely on blood pressure recorded by paramedics and junior doctors. Listening since morning, so two times, 3 times, because it is important, because all stroke patients have reactive hypertension. Especially in hemorrhagic stroke, that is very common. So just don't take any decision based on a single reading. Check the BP apparatus regularly. That it can be faulty, and so giving rise to faulty readings, taking and pushing us to take wrong decisions. Use correct size cuff, especially for obese patients. So I've shown this obese cuff is there. People who have obesity, and then preferably use mercury BP apparatus. There can be controversy into that, but I think it's easy to use and gives proper readings. As we know, hypertension causes, what happens in hypertension is the force of blood pushing against the blood vessel wall is high. So there is a more pressure. What is systolic pressure? Is the pressure in artery when the heart beats, and diastolic when the pressure in the heart arteries when the heart rests between the beats. Hypertension damage arteries and organs over time. So there is a wear and tear effect on the arteries, on the pipes. We can imagine it as a water pipes. So over the years, these pipes, they have wear and tear effect. If the pressure is high, they tend to get blocked or get ruptured. So there can be endothelial damage, which causes narrowing of the artery and ultimately resulting into ischemic stroke. High blood pressure strains blood vessels. Over time, they no longer hold up to the pressure and rupture and produces hemorrhagic stroke or IC bleed, which we commonly refer to as. What are the mechanisms? High intraluminal pressure causes extensive alteration in endothelium and smooth muscle function. There is an endothelial stress which increases blood-brain barrier permeability, causing brain edema. There can be endothelial damage and altered blood cell endothelium interaction, causing production of local thrombus, which causes blockage of the arteries. There can be fibrinoid necrosis, which produce small lacunar infarcts, and ultimately this fibrinoid necrosis can produce gangliocapsular bleeds. Hypertension accelerates arteriosclerotic process, causing stenosis of large extracranial and intracranial arteries, and these atherosclerotic plaques can embolize, producing atheroembolism. Stroke is the most common cause of mortality worldwide. It is the third most common cause of disability. And hypertension is the most prevalent risk factors. It is seen in around 64 have stroke. What is stroke? It is defined as rapidly developing clinical signs of focal or global disturbance of cerebral function, with symptoms lasting 24 hours or longer or leading to death. There is a controversy regarding this 24 hours. We'll see this matter in few minutes. There is no apparent cause other than vascular origin. So there is a problem with vasculature. It has ruptured, causing neurological signs, that is stroke. We know what are the types of stroke. Grossly, there are two types of stroke, ischemic and hemorrhagic. Ischemic is more common, around 83 to 84%. Hemorrhagic is around 13 to 16%. And out of these ischemic stroke, 51% has thrombosis, embolism. Embolism is usually from the heart, or it can be atheroembolism, and there can be large or small vessel disease. Hemorrhage, there is intracerebral hemorrhage or subarachnoid hemorrhage. There are various manifestations of brain damage caused by hypertension. It is not just stroke. There are a few more things which are produced by hypertension. We know about ischemic stroke, that can be TIA or infarct. Hemorrhagic stroke, there can be IC bleed, parenchymal bleed, or subarachnoid hemorrhage. There can be cerebral small vessel disease, which ultimately produce dementia kind of picture. There can be PRES, which is called as posterior reversible encephalopathy syndrome, or RVCS, reversible vasoconstriction syndrome. Hypertensive encephalopathy is the manifestation, and ultimately small vessel disease can produce vascular dementia and Parkinsonism. So we know this is ischemic stroke. There is a blockage of the artery, and in the hemorrhagic stroke, there is a rupture of the artery. It's very simple. To come to some conclusion, to make complete diagnosis, it is important that we have all the investigations at our hand. We have to image the parenchyma, we have to image the vessel, and we have to investigate about the end organ damage. That will give the complete diagnosis to us. So in this era also, some people ask, is CT scan and MRI necessary? I ask them, in a case of chest pain or heart attack, is ECG is necessary thing or not? They'll say, yes, it is necessary. So it's as simple as that. CT scan is a must, or MRI, whatever it is, imaging is must, preferably MRI. So we have to image parenchyma, we have to image the vessels. This is circle of Willis, extracranial and intracranial blood vessels, and we have to see the end organ damage in the form of cardiac involvement, renal involvement, liver involvement, ocular, and so forth. So what happens over the years? There is a hypertension causes acceleration of arteriosclerotic process, which produce plaque, and these plaques are common at the sites where the artery is getting branched, because the traction or shear effect is more, so they get plaques at the branching. So there can be angionecrosis producing small lacunar infarcts and ultimately hemorrhage, or there can be atherosclerosis causing large artery involvement, or there can be cardiac embolism. To begin with, TIA. TIA is almost previous definition of TIA was something which is lasting for less than 24 hours, but nowadays it has changed and still it is evolving. TIA nowadays are referred to all neurological symptoms caused by vascular problems in the brain, and which last for less than 30 minutes actually. But let us see less than 1 hour, because more than most last less than 10 minutes. And if the symptoms are persistent after 10 minutes and after 1 hour, they usually have small infarcts and it is not TI. So what happens in ischemic stroke? There is a blockage and blood vessel is occluded, causing ischemia and infarction. What happens in TI is at the site of branching, there is a atherosclerotic plaque producing reduced blood flow. So it is not totally occluded, producing TIAs. And if it gets ruptured, that produces hemorrhagic stroke. So we saw there is a atherosclerotic plaque which is getting accumulated at the bifurcation and usually it produces TIA. Again, this is the healthy artery and this is the plaque which is at the branching site and producing less blood flow and causing transient ischemic attack. This is ischemic stroke. You can see the infarct is there in the left MCA territory area. So this is how MR is important because it picks up the infarcted area very early. Initially, on the day one, first 24 to 48 hours, CT scan may not show anything, and we are misguided by a normal CT scan. So in this case, we see this is MR angiography and this is ICA. This is a both vertebral joining to produce basilar artery and PCAs we can see. And these are ICAs and these are MCAs. On the right side, MCA is seen clearly and there is a cutoff on the left side of the MCA producing left MCA infarct. So this is again ischemic stroke. You can see the hypodensity. So gradually, roughly, we can say that the infarct appears hypodense on CT scan and hyperintense on MRI, T2-weighted, and diffusion. So the important thing to know is on day one, the CT scan may be negative. On day two, it will show infarct. But as we progress, like for example, day 3, day 4, day 5, especially day 4 and 5 are dangerous, where the edema and the infarct size increases. And if you don't repeat the CT scan or MRI, you might land into problem because the patient might cone due to raised ICT infarct and might suddenly deteriorate and we might lose the patient. So it is very important to clinically observe these patients and repeatedly do the imaging. Again, we can see the left MCA infarct here, and this is a large infarct, right? MCA infarct. This is a evolved infarct, maybe day 3, day 4, and they carry bad prognosis. And there's a bleed. There are 3 types of bleed. This can be subarachnoid bleed. They can be basal ganglia. This most common cause is hypertension, as we have seen. This is the most common site where hypertensive bleeds occur. If there is a subarachnoid bleed, usually the cause is aneurysm. And if the lobar bleed is there, the other, apart from hypertension also can produce lobar bleed, but we have to look for amyloidosis, venous infarctus, or AV malformations. So here it is very clear, this is a subdural, this is a below subdura, this is a epidural. Usually trauma causes subdural and epidural, and this is intracerebral hemorrhage, which is usually caused by hypertension due to fibrinoid necrosis of small thalamocyte arteries, and subarachnoid hemorrhage, which is usually caused by aneurysms. The typical sites, this is a lobar bleed, this is a putaminal hemorrhage caused by hypertension, thalamic hemorrhage, there can be pontine hemorrhage and cerebellar hemorrhage. These are the various sites where bleeding can occur due to hypertension. As we have seen, the blood can go into the ventricles, causing ventricular extension, and in a way it decreases the intracranial pressure, but usually the complications are more. They can be different in sizes, like this is cerebellar bleed causing compression of the brain stem, and these patients might need decompression or sometimes external ventricular drain because of hydrocephalus caused by obstruction. This is a gangliocapsular bleed left-sided, and this is a large bleed, has very poor prognosis. Whatever you do, usually the patients succumb. This all happens because of hypertension. So again, there's a small bleed, there's a large, there's a thalamic bleed, there's a cerebellar bleed or bleeds. So usually bleeding doesn't occur due to rupture of large vessels. Usually it occurs because of the rupture of thalamostriatic arteries. These are small arteries which are ruptured because of raised blood pressure. There is a fibrinoid necrosis, and if the patients with lacunar infarct, they have high chances of getting bleed if the blood pressure is not controlled. You can see this is subarachnoid hemorrhage, where you can see the hemorrhage in the arachnoid spaces. This is a typical spider-like appearance of the SAH. SAH is not commonly caused by hypertension, very rarely. We have to document, we have to do DSA and to rule out aneurysm and if the blood pressure is high, because there can, as I said, there can be reactive hypertension, and we might go thinking that hypertension has produced subarachnoid hemorrhage, but usually that is not the case. It is a reactive hypertension which causes um, uh, raised BP readings. Subarachnoid hemorrhage is commonly caused by aneurysmal bleeds. Hypertensive encephalopathy, the patient will present with severe headaches, confusion, blurring of the vision, and as we saw in the mechanisms, the persistently high blood pressure will cause breakage of blood-brain barrier and causes edema. And this is a typical picture of hypertensive encephalopathy. Then there's something called as posterior reversible encephalopathy syndrome. As we can see, the areas affected are usually posterior, so the patients will present with visual disturbances and seizures. This is very common in patients with eclampsia, prenatal or postnatal. The people who have fluctuating blood pressure, people on immunosuppressant drugs, after blood transfusion, in malignancy, press can happen. And then can be atypical press also, as we've seen. It may not be posterior always, but it can be anterior. It can affect the basal ganglia also. They can be atypical press. There's a syndrome which is called as reversible vasoconstriction syndrome. This is also the pathophysiology is almost similar to press. So there can be infarcts seen, especially in posterior region, but anywhere it can be seen. And you have to demonstrate that there is an involvement of the arteries. So the typical pattern which is seen on angio is beaded arteries, which are seen on MRI, MR angio, CT angio, or DSA. And the patient will have severe headaches and hypertension. It is not a compulsory thing to have hypertension, but and this is a typical condition where the vasoconstriction is reversible. When you do DSA or angio after 10 days or so, the angio is normal. There can be Binswanger's disease. As I said, it can affect the small vessels of the brain, causing leukoariosis and white matter lesions, periventricular, and this produces typically dementia, gait abnormalities, and forgetfulness is the presentation. The presentation would be like vascular Parkinsonism. So hypertension can produce stroke. Hypertension can produce white matter lesions. It can produce cognitive impairment and dementia. Ultimately, that's the end result of long-standing hypertension, which is producing either recurrent strokes or white matter lesions, producing higher mental function affection. So ischemia or white matter disease, focal brain atrophy, amyloid accumulation. But these two changes, because of hypertension, will produce dementia. As we can see in this slide, this is a healthy brain, the brain with diffuse white matter lesions or small strokes. And as it progresses, as the blood pressure remains high, it produces atrophy of the brain due to extensive white matter involvement. There's a brain atrophy and brain is shrunken, producing dementia, which is called as vascular dementia. We can see there is extensive white matter involvement. There can be microbleeds also, producing atrophy and brain changes leading to vascular dementia. You can see there's a mild few lesions, periventricular white matter lesions. There's a moderate multiple lesions and extensive lesions in severe vascular dementia. This is cerebral small vessel disease. As we know, it can affect the small vessels. Hypertension can affect the small vessels, producing white matter hyperintensities, lacunes, enlarged perivascular spaces. There can be cerebral microbleeds, multiple of them, hundreds of them in the brain, present small subcortical infarcts, brain atrophy, and cortical microinfarcts, all of them leading to ultimately vascular dementia. These are microbleeds seen on gradient imaging, multiple hundreds of them. These are effects of long-standing effects of hypertension, which is uncontrolled. So microbleeds can be there. So ultimately, this all changes, white matter changes and small vessel disease, they produce dementia. It can be isolated vascular dementia or it can be Alzheimer's dementia. But most common dementia which is seen in India is usually mixed dementia. They have some part of it is because of Alzheimer's type of dementia, and most of the part is because of vascular dementia due to prevalence of hypertension and diabetes in our community in Indian subcontinent. So hypertension primary prevention of stroke is important. There was a study, SPRINT, systolic pressure intervention trial, which said that decrease the goal from 140/90 to 130/80 for primary prevention of stroke. Patient has never got a stroke, but we have to prevent the stroke. This is a primary prevention, but overall consensus is target blood pressure of 140/90. Hypertension is commonly seen in ICH, though it can be reactive hypertension. But if it is very high, systolic BP 150 to 220 with no contraindication to acute BP treatment, acute lowering of BP to 140 is safe. Systolic BP of more than 220 needs aggressive reduction with parenteral drugs. We'll see what are the drugs which are used commonly in our ICU. Hypertension is linked to greater hematoma expansion and poor prognosis. Why is it important? Because if you keep the blood pressure high, the hematoma can expand, producing very poor prognosis. If the BP is rapidly controlled, there are more renal adverse events, which are obviously seen. In hypertension in acute ischemic stroke, nowadays, there's no only veranda treatment for stroke patients. As we saw in our Ghati days, stroke means admit in veranda and do nothing. You just give aspirin, RT feeding, and catheterization and physiotherapy. But now the things have changed over last few decades. We can thrombolize these patients. If the patient is in window period, reduce the systolic pressure to less than 185 and diastolic to 110 before thrombolysis. Because lowering the BP helps in decreasing hemorrhagic transformation after lysis. Because around 6% of these patients who receive thrombolysis will have hemorrhage, and sometimes these can be fatal hemorrhage. Sometimes they might need craniotomy also. So if you control the blood pressure before lysing, the chances of hemorrhagic transformation are drastically decreased. If no lysis but intraarterial therapy is planned, like mechanical thrombectomy, maintain the blood pressure less than 185 above 110 before the procedure. A rapid reduction in BP can be detrimental. But nowadays, studies are there in which they have documented that rapid reduction is not that harmful as it was thought. BP should be cautiously lowered by about 15% during the first 24 hours. Patients with acute ischemic stroke and BP of less than 180/105 in the first 72 hours after stroke don't seem to benefit from antihypertensive drugs. So we have to wait and watch. Don't jump onto conclusion. Don't start treatment because it can be just reactive hypertension, especially in hypertensive bleeds. So wait for 72 hours if it is not harming anything and if you are not going for any interventional treatment. For stable patients who remain more than 140/90, more than 3 days after acute ischemic stroke, if it is persistent after 3 days, sometimes people say up to 7 days, then initiation or reintroduction of antihypertensive should be considered. restarting blood pressure control is reasonable after the first 24 hours for a hypertensive patient who was stable. If the patient is known hypertensive, restart after 24 hours. If he is a new patient, not a known case of hypertension, then you can wait for 3 days. If it is not emergency, of course, if the patient is stable. If it is emergency, you have to treat. Hypertension and secondary prophylaxis of stroke. Patient with underlying hypertension less than 140 by 90. Patient with lacunar infarct, as I've already mentioned, the target is less because here the chances of hypertensive bleed are very high. Patient with hemodynamically significant large artery disease, BP should be reduced cautiously. And the patients who develop recurrent neurosymptoms, which are referable to stenotic artery, when the BP is lowered, they get symptoms. So in these cases, we have to maintain the BP above threshold. We have been hearing about these drugs, very simple: A, B, C, D. A for ACE inhibitors, ARBs, alpha blockers, B for beta blockers, C for calcium channel blockers, and D for diuretics. Pril, everything pril is ACE inhibitors, sartans is ARBs, osins is alpha blockers, LOL is beta blocker, dipine is calcium channel blocker, and IDE is diuretics. And we have seen the speakers speaking about the judicious use of these various molecules in different conditions. As we know, if my patients are usually not stroke patients, they will be having bronchial asthma, COPD, diabetes, CKD, and whatnot, hypothyroidism, everything. So they are usually, these things go hand in hand, as Dr. Hassan told us. So calcium channel blockers are preferred when the patient has COPD and bronchial asthma. Young patient, of course, diuretics, ARBs, or combination of these drugs. As the previous speaker has also told, we don't prefer diuretics in elderly people because of two things. One is hyponatremia. Second, I've noticed that they get syncopal attacks, and which can be very dangerous, causing falls and fractures of the bones. CBD, judicious use of new beta blockers, and when BPH is there, alpha blocker, and avoid ARBs in CKD, that we all know. Hypertensive emergencies में the three molecules which are used, one is sodium nitroprusside, another is nitroglycerin, labetalol. People have been using nitroglycerin for hypertensive emergencies in stroke also, but that has been discouraged now. This is sodium nitroprusside, which is available in 2 ml vials, 50 milligram per 2 ml. So this is a very nice molecule for hypertensive emergencies. It has to be given in IV infusion, 0.25 to 10 micrograms per kilogram per minute IV infusion in 5% dextrose. A separate line is needed and it should be covered because light should not fall on this molecule. So we have to keep it in dark. So the separate arrangement for administration is required. And nitroprusside is better in patients with raised ICP, which is seen in large infarcts and ICDs. As I said, nitroglycerin is preferred when there is associated coronary ischemia. So few patients will have acute myocardial infarction, and then later on they'll develop acute ischemic stroke also. These patients may be coronary ischemia. Since it is there, nitroglycerin is better. Otherwise, routinely we don't encourage using nitroglycerin in patients with stroke. And the most handy treatment is injection labetalol. Dr. Lakas also was telling, Lobet injection, 20 to 80 milligram IV bolus every 10 minutes. We have to continuously monitor, or we can give in infusion 0.5 to 2 milligram per minute IV infusion. It's good in all hypertensive emergencies except acute heart failure for the obvious reasons. So we have discussed about this also, and then this is the algorithm showing how it should be managed. The important thing is whether the patient is going for thrombolysis and mechanical thrombectomy. If he's in the window period, the targets will be different. And if he is not going, if he's out of the window period or not going for lysis or mechanical thrombectomy because of other reasons, then the goals are different. Of course, we have to speak about the lifestyle changes also. We have to encourage our patients and tell them and make them aware of the importance of lifestyle modification, get active, eat better, lose weight, stop smoking, control cholesterol, manage blood sugar, and reduce blood sugar. All these things are very important in preventing stroke. What are the take-home messages? Hypertension is the most prevalent risk factor for stroke. It is the most important treatable factor for stroke prevention, primary and secondary. Hypertension-induced brain damage can manifest in many ways, not just stroke. As we have said, it can produce Parkinsonism, it can produce dementia over the years. Goals of BP lowering vary from condition to condition and situation to situation. A rapid fall is not warranted except for thrombolysis or mechanical thrombectomy or severe hypertension. So there can be reactive hypertension. Beware of that and don't take decision based on initial readings. Lifestyle modification is very important, but it is not very stressed upon. Thank you for kind listening. And I'm grateful to GU and Professor Shafi Saab and Dr. Hazi Saab for giving me this opportunity to present neurology of hypertension in front of this audience. Thank you.
Thank you, sir. It is our honor that you, after taking so much pain, you have arrived here, and you are such a busy person, and you took out time for this talk. So, Elite Academy, and on behalf of JUICE IMSR, I thank you very much.
Thank you.
Now we will start with our short inaugural function. We have the Dean, the Dynamic Dean of Indian Institute of Medical Science and Research, our chief guest or for today's webinar, to whom you were listening, Dr. Abdul Majid sir. And we will start a bit of felicitating function of Majid sir because it is very important that he has came in person and attended.
आपको बात करेंगे तो
Started. Absolutely. Karo. Like to request our team sir. I would like to request our team sir to kindly say a few words about this webinar.
Good afternoon, all. It's my pleasure to host you for this CME. Being online CME this time, our delegates are not only from the city, but from the state, nation, and also abroad. And online CME is having its own advantages. People can attend it from anywhere. Some disadvantages also there. We cannot have lunch together. Somebody is taking lunch on his own. I can see that. Our college is situated in a rural area at the border of Aurangabad and Jalna district. So we are arranging 3 CMEs per year at our institute. But people from Aurangabad, it's difficult for them to arrange to attend all those CMEs. So we have started this concept of keeping 3 CMEs in the city. So the people in the city can attend. But this time it's the first time that we are arranging an online. So people can attend from outside also. And it gives me a great pleasure also to share the screen with one of our mentors, Dr. Abdul Majid sir, who has been supportive throughout all our activities. Whenever we give a call to him, he has never said no. I've never heard a no from him in spite of all this busy schedule. And I once again welcome you all, and I hope that you are enjoying the academic feast today. Other feasts, as I said, cannot be enjoyed online, but at least you are enjoying the academic feast. And I wish all the best to all the hosts, as well as all the speakers. I once again welcome all the speakers also from various parts of India who have attended this CME. And I wish all the best for the remaining section also. And with this, I thank once again Majid sir and all the other speakers who have attended and we have given a lecture on this. And I have seen this online. I was attending it in the morning. Everybody was very enthusiastic. They were very effective. to the point. And I hope that after this end of this CME, we'll have a good gain of knowledge in our respective fields. Thank you all. I missed one point. I thank especially Dr. Shafi, Dr. Zubair, and Dr. Jawad for arranging and taking all this pain because it's the first online CME. So there may be some technical glitches. Whatever we try our best, there is always some technical glitches. In spite of that, they have kept a good rapport. They have kept a good momentum as well for this. Only half an hour late, I think, is going on, but they will cover that time. So thank you all.
I thank you very much, sir. Now I request our chief guest, Dr. Abdul Majid, sir, to kindly enlighten us with his vision of medical education.
I think he is really close. I feel honored to be here to inaugurate the CME. This has been going on since morning, and we all know the importance of knowledge in our respective field and the importance of updating ourselves. It is said that either you get updated or get outdated. So we have to update ourselves continuously, and there's a tremendous effort from the GU people and LH Academy, which has been presenting these opportunities to all of us to update ourselves. It is not that these points are important and we have to earn these points to renew our registration. That is one part of it. But the important part is by sitting at home also, we are enjoying the feast of academic knowledge and excellence and experiences of lots of experts in their respective fields. So this is not a small thing. This is a very big thing which needs congratulations. I congratulate all of them, especially our Dean Dr. Azhar Siddiqui Saab, Professor Shafi Saab, a young dynamic Dr. Hazi Saab, and Dr. Jawad. They are doing and taking tremendous efforts to arrange this. This is not easy. This is not simple as it looks. It takes time, effort, and a lot of perseverance to arrange these kind of CMEs and get it over successfully. So I congratulate and declare this CME as inaugurated. Thank you.
Thank you, sir.
Thank you very much.
Sir is very kind. Sir is our actually teacher. He is my teacher. So we are honored to be his students.
Now I request our Dean sir to kindly felicitate our chairperson and chief guest, Dr. Abdul Majid sir, by presenting a shawl and memento.
Sir, बैठिए. Thank you, sir.
Thank you.
सर हम यहाँ से तालियां बजा रहे.
I think hypoglycemia.
Yes, definitely. We are listening, madam. We know your good vibes are with us.
Yeah, thank you. It's a great
Delegates are
session.
telling that they are clapping from their side.
Okay. Thank you very much for that.
Thank you. I request the director of Elite CME and professor of PSM department, Dr. Shafi sir, to kindly felicitate our dean sir, Dr. Azhar sir, dean of Indian Institute of Medical Science and Research.
Is it necessary to felicitate the host also?
No, sir, it is just a token of gratitude.
Thank you.
So, here I get a chance to get felicitated by the esteemed members present here. I request Dean sir to kindly felicitate Shafi sir. He is one of the person who is very much motivated in the team of Elite Academy.
I request Majid sir also to join me because we are colleagues. It is honor to be felicitated by Majid sir. Thank you.
Now I request Dr. Jawad sir, the playback singer of Elite Academy. He does not come on screen much, but he is one of the most helpful person. I request Dr. Majid sir and Dean sir to kindly felicitate Dr. Jawad sir with shawl and memento.
Thank you very much.
And as you all can see that I am also taking very much efforts. So I request everyone to please present me my memento.
All of us are lucky that we are getting felicitated by one of our mentors from Aurangabad.
Thank you.
Maximum talia, maximum claps for you. Great.
Thank you, madam. Some delegates are telling that maximum claps are for me.
Because he facilitated.
Thank you very much. So we'll continue with our session. I would like to thank all of our esteemed guests to being here, and we will continue with our session. I would like to involve Dr. Faisal Hilli sir with his introduction just in 2 minutes. So our next speaker is very dynamic and very genius psychiatrist, sir, Dr. Faisal Khilji sir. He has done his MD in psychiatry from Government Medical College in Gujarat, and he has done his fellowship in psychiatry. He has done many certificate courses, one of which we would like to highlight at this moment is de-addiction psychiatry. He is an expert in that, and child psychiatry, one of his expertise, and he is also working as male sexologist, one of the uh, understood stigma of the society, but sir is working in that. Sir is associated to many of the psychiatric associations and has conducted workshops and training for young psychiatrists. Sir is a co-author in the book of uh, sorry, uh, uh, हमारी नफ्सियाती सेहत. The book, sir is co-author in this book. He is also an academician, an ex-associate professor from Badnapur Medical College, that is Indian Institute of Medical Science and Research. I request sir to kindly share his screen and he can continue with the session.
Thank you, Dr. Jawar. Can you hear me? Am I audible?
Yes, sir. I can hear you, sir.
Is my presentation visible?
Yes, sir. Your presentation is visible. Okay, sir. You are all set for the session, sir.
Okay, thank you.
Thank you.
So, without taking much of your time, I would like to thank the organizers for giving me an opportunity to give a talk on this topic. As we all know, that today's CME is on hypertension. I would like to highlight the connection between hypertension and anxiety disorders. So, first of all, let us see the as we all know, we have heard since morning what hypertension is, but as everybody stressed upon the fact that for managing the hypertension properly, what we need is there should be lifestyle modifications, appropriate medical interventions, as well as reducing the health risks, adopting a healthy lifestyle, balanced diet, regular exercise, and stress management. And that is very important topic that is linked to anxiety and psychological problems. So, coming to just an overview about psychiatric disorders, we know that these mental health disorders, they are close to 60 to 70 million people in India. They suffer from common and severe mental health disorders, according to a Lancet study. Well, actually, according to WHO, it says that almost every second person suffers from a mental health disorder in their life once at least. And at a particular period of time, cross-sectionally, if we see, 1 in 4 of us, they suffer from one or another psychological problem. So that can just give us the idea about the immense burden that these psychological problems have. So coming again to this, a complication of those psychological problems is suicide. India has been identified as the world's suicide capital with over 2.6 lakh cases of suicide reported annually. So it's a very shocking and frightening data, and that indicates the need for handling these mental illnesses properly. And the most, I would say, the challenging task in this is the handling the stigma associated with mental illness. Mental illness continues to carry a stigma in India, which can hinder awareness, timely intervention, and access to mental health services. So, what is needed, in fact, is a comprehensive approach, multifaceted strategy, awareness camps, campaigns, destigmatization efforts, increase access to mental health services, policy initiatives, and public education and community engagement that all can lead to a better future and better control of these mental health problems. Now, coming to the topic, anxiety. What is anxiety? Actually, everybody of us feels anxious. Anxiety is a natural response to stress. It is characterized by feelings of fear and worry. It's a normal part of life, and it can be triggered by various situations and events. Excessive prolonged anxiety that interferes with daily life may indicate an anxiety disorder. That is the difference between having anxiety or an anxiety disorder. If that prolonged and excessive anxiety is interfering with our daily life, then it becomes a disorder. And the common symptoms of anxiety disorders are restlessness, tension, racing thoughts, physical manifestation like increased heart rate, and of course, can lead to many physical illnesses, even hypertension. So, anxiety disorders, they represent a group of mental health conditions which are characterized by excessive persistent feeling of fear, worry, or apprehension that can significantly impact daily life. And there are several types of anxiety disorders, each with unique features. So the first one is generalized anxiety disorder, and we'll see what it actually is in later slides. Panic disorder, social anxiety disorder, specific phobias, OCD, and post-traumatic stress. Now, just to sum up, I have presented this presentation, I have made this presentation in a way that we can relate with the day-to-day cases that we see in our OPD and try to explain that how these cases are interconnected with the psychological problems like anxiety. And as said by many of my physician colleagues, that almost 50% of the patients that they see in their OPDs are actually psychological patients who don't know where to go, and they actually have psychological issues. So let us look at this first case. A 28-year-old female with a chief complaints of recurrent episodes of intense fear and discomfort. And the HOPI patient reports experiencing sudden, unpredictable episodes of overwhelming anxiety, accompanied by physical symptoms such as palpitations, sweating, trembling, and feeling of impending doom. These episodes last for about 10 to 15 minutes and occur unexpectedly. The patient worries about having additional attacks, leading to avoidance behavior. So there's no significant past medical history, and the family history is also negative. Social history. The patient works in a high stress environment and reports recent life stresses, including a change in job responsibilities, and there's no significant trauma or abuses. Developmental history is normal, like so, and the patient describes increased stress at work and challenges in managing her work-life balance. And there's patient not on any medications. According to the DSM-5, the patient is suffering from panic disorder. There's no evidence of any medical condition contributing to symptoms. Now let us just try to recollect. A lot of patients like this, they are coming to the routine OPD. Maybe you also have seen such patients coming to your OPD. So this is how a patient of panic disorder comes to the OPD. The typical symptoms will be अब सर सीने में बहुत दर्द हो रहा है, घबराहट हो रही है, दिल की धड़कन तेज हो रही है, बेचैनी हो रही है, और कहीं डर लग रहा है कि कुछ हो जाएगा. And when you check, the BP is absolutely normal, the patient is relaxed, and in definitely when the time of panic attacks, there can be a slight raise in the blood pressure. But otherwise, in between the attacks, the patient is absolutely normal. Patient is but having apprehension that he might have some cardiac illness or some major illness or hypertension, and all these kind of fears the patient has. And this is how we have to reassure and treat the patient. We have to, of course, do psychoeducation of the patient that this is not a severe physical illness. It's just, it's a psychiatrical illness. And we have to reassure that, okay, if you get the proper treatment, we'll be fine. And what are the treatment? First of all, psychotherapy, have to counsel the patient. And the common one is CBT, cognitive behavior therapy, that addresses the maladaptive thought patterns and behavior. So basically, everybody has got some patterns, thought patterns, and behavior. Each one of us has a pattern of thought and has a pattern of behavior that is embedded in us. Some of those patterns and behaviors are, some of them are negative or maladaptive. So this happens when the maladaptive thoughts and patterns, thought patterns and behaviors, they are, increasing. They are leading to this anxiety. So we have to correct those thoughts. What are the wrong thoughts? Patient might be catastrophizing, thinking, yeah, if I have those symptoms, I heard somebody having those symptoms and they had a heart attack and they passed away. So some patients might think, okay, उसको ऐसा हुआ तो मुझे भी हो. Was an age. You are a
Recording
healthy
in progress.
person, you don't have any medical history, your BP is normal, ECG is normal, there's nothing like that. So this kind of CPD, correcting those thoughts, you are catastrophizing, you are just overgeneralizing. These kind of wrong cognitions you have to correct, and if required, obviously you can start the patient on pharmacotherapy such as SSRIs, and also for a short period of time we can give some anti-anxiety medicines like tranquilizers or benzodiazepines for a short period of time, and as the patient becomes fine and stable, gradually those medicines can be tapered off. So this is how actually we treat the patient with anxiety, especially the panic disorder. Now let us just see rapidly what are the criteria of a panic. So coming yes. What are the criteria? Sudden intense apprehension, fear or terror, and then a rapid development of at least 4 of the following: palpitations, sweating, trembling or shaking, sensation of shortness of breath or smothering, feeling of choking, chest pain or discomfort, nausea or abdominal distress, dizziness, unsteadiness, lightheadedness or fainting, derealization, depersonalization, fear of losing control or going crazy, fear of dying, numbness or tingling sensation, chills or hot flashes. So any 4 of these symptoms, if they are present, then it amounts to be a panic attack. And what is panic disorder? If you are having recurrent panic attacks, at least one of the attacks has been followed by a month or more of one of or both of them, persistent concern or worry about additional panic attacks or their consequences, and a significant maladaptive change in behavior related to the attacks, and this becomes a panic disorder. Now, panic disorder is actually uh, quite underreported. Like we can see in the study, the lifetime weighted prevalence is 0.5%. And of course, male gender and unemployed individuals, they have a high incidence. And elderly individuals, those in urban metro areas and the married group, they have significantly lower incidence. Comorbidities, most common comorbidity are psychiatric disorders, of course, like agoraphobia, that is fear of places from where escape can be. So the person with panic disorder will classically present with fear of going in a crowded place, fear of going in a closed place, fear of traveling in a public transport like a bus or a train or aeroplane, where they cannot just to stop the transport, stop the vehicle whenever they are having a panic. This kind of fear that if I have a panic attack, what will happen? How will I recover from this? If a lot of people they restrict themselves to their homes and to the localities, and they are not comfortable to travel alone. These kind of symptoms are present in agoraphobia. And obviously, depression, anxiety, and depression go hand in hand. If you have severe anxiety, you're bound to, you're at risk to go in depression. And also, generalized anxiety disorder is present in 10% of the cases. And of course, around 80% of the patients with current panic disorder had some level of disability, and 20 to 25% had marked disability. And of course, as I told you about the stigma and the lack of education, psychoeducation, knowledge about these diseases, it's so common in us, the doctors. So how would the common people know much? So the treatment gap is again huge. 71.7% of people, they actually don't get the right treatment that they deserve. Now just coming up to the second case. This case is of a 45-year-old male. He was having elevated blood pressure readings, especially at the doctor. Patient reports consistently elevated blood pressure readings during medical appointments, but normal blood pressure measurements at home. Episodes of increased anxiety and nervousness, specifically during medical visits, are noted. Past medical history is negative, the patient is generally healthy, and family history is positive for hypertension, with both parents having diagnosed. So that again creates a lot of anticipation and fear in the patient that like my parents have blood pressure, maybe I will develop blood pressure, and that kind of thinking sometimes make the patient act. Social history: the patient works in a demanding job and reports high level of stress, particularly related to work responsibilities. There's no history of substance abuse, and developmental history is normal. Psychosocial history, again, the patient acknowledges feeling anxious and uneasy during medical appointments, often anticipating a rising blood pressure, and there is no significant recent life change or losses. Medication history, the patient is not on any medication for hypertension or other medications. And according to the, what's the diagnosis? So this patient is actually suffering from white coat hypertension, most probably, and um, we can confirm this by ambulatory blood pressure monitoring that we'll see later on. And yes, of course, patient needs. How will we actually know what is it white coat hypertension or is it real hypertension? So let us understand what is white coat hypertension. It's a form of labile hypertension in which people exhibit an elevation of blood pressure level in a clinical or hospital setting, although they do not exhibit the same in other settings. And as it is said, it is not this that white coat hypertension patients are actually not having blood pressure. Sometimes they actually have blood pressure, but what happens is the blood pressure is not that severe when the patient is at home, and when the patient comes to the clinic, the blood pressure actually shoots up. So that leads to a overdiagnosis, and sometimes the patient are given over medication, and that leads to the problem. And what is again, the ambulatory monitoring is very important. In 24-hour ambulatory monitoring of the blood pressure can let us know actually how the average real-time blood pressure of the patient is for the most of the time of the day, and whenever it is increasing, is it increasing only at the doctor's clinic? And management again is relaxation techniques, suggestions for overcoming anxiety during BPA measurements, and again, ambulatory blood pressure monitoring for the confirmation, and follow-up recommendations very important. We should regularly monitor those patients, and we should reconfirm the diagnosis. Maybe later on, turn up to be patients of actual hypertension, or they might be, suffering from some or the other psycho. Now, coming to the third case, this is a 35-year-old female who is in recurrent panic attacks with a specific fear of developing hypertension. Like The patient reports experiencing sudden and intense panic attacks characterized by palpitations, shortness of breath, and sense of impending doom. And a distinct aspect of the panic attacks, the preoccupation with the fear of hypertension, often exacerbated by concerns about impact on overall health and past medical history is insignificant. Heightened awareness of health-related issues and frequently monitors blood pressure at home. We all have seen, I think, these patients who just keep on, as taking their blood pressure every day and many times a day, and they have a very strong fear of getting hypertension. So this kind of cognitive distortion that they have, that if I have hypertension, then I think my life is done. So this leads to all the anxiety. So on the family history, it was negative for panic or hypertension. Social history, the patient has a busy lifestyle and has difficulty in balancing work and family. There are no significant stressors or recent changes, no substance use or smoke. Normal developmental history and psychosocial history shows the patient has health-related anxiety and a persistent fear of development. There is increased focus on physical sensations, leading to heightened worry and depression. What these patients tell us. अगर मुझे बीपी नहीं है तो मुझे छाती में तकलीफ, अगर मुझे बीपी नहीं है तो why am I feeling dizzy all the time? Why I have this feeling of I have these palpitations, why I have these tremors, why I have this sweating, and they don't actually know that these are because of the anxiety that they have. It's not because of blood pressure. This fear of getting blood pressure actually is because of their anxiety, and this leading to the the diagnosis or development of anxiety. There's no use of medications for mental health concern, but there is limited use of over-the-counter medication for anxiety. And diagnosis, according to DSM, is a diagnosis of panic disorder with a specific phobia of developing hypertension. No evidence of medical conditions contributing to the symptoms. Treatment plan, again, recommendation from CBT to address the wrong patterns of thought, psychoeducation about the nature of panic attacks and the association with hypertension fears, collaboration, with a healthcare provider for periodic blood pressure monitoring and reassurance. Follow-up appointments again and monitoring is very important, and they should be encouraged to communicate with the healthcare provider, address the concern that the patient has about blood. And again, the prognosis with appropriate treatment and the panic disorder with specific periodic hypertension is generally favorable. So CBT is again very useful in managing these. Now, coming to specific phobia, like this patient was having that specific phobia of developing hypertension. A lot of people accept hypertension like it's a normal, it's a stage of life, or it's something that happens to most of us. So there's nothing to worry. You can live with it. But a lot of people have a specific phobia, that irrational fear of getting hypertension. So specific phobias are irrational fears of specific objects, situations, such as heights, animals, or flying. These phobias can lead to extreme avoidance behavior and can significantly impact daily life. Like I have a patient who comes daily to my clinic because of this anxiety. I have to counsel him and assure him, and that is actually a very big task. Exposure to the feared object or situation often triggers intense. Now coming to the case 4. This patient is a 40-year-old male having the chief complaint of persistent anxiety with a specific fear of experiencing a heart attack. So, history of the present illness: the patient reports ongoing anxiety characterized by worry about his heart health. Specific fears revolve around the possibility of having a heart attack, leading to increased vigilance regarding physical sensations and symptoms such as chest discomfort, shortness of breath, and palpitation. Anxiety often intensifies when engaging in activities that may be perceived as physically demanding. This person doesn't have a fear of getting hypertension, but actually has a severe fear of getting a heart attack. The past medical history is absolutely normal, no cardiovascular problems, negative family history for heart disease or anxiety disorder or early onset heart disease. Social history: the patient again has a high stress job, difficult in balancing the family and the profession, limited social support, no history of substance abuse. The developmental history is no. Psychosocial, patient acknowledges experiencing chronic stress related to family with heightened anxiety, specifically surrounding heart health, sleep disturbances, and fatigue. Medical history, medication is negative, and again, the diagnosis of generalized anxiety disorder with a specific fear of having a heart attack is made. Treatment plan, again, CBT, relaxation, and medication. And now, what is generalized anxiety disorder? It involves chronic and excessive worry about various aspects of life, often without a specific treatment. Individuals with GAD may experience persistent feelings of tension, restlessness, and irritability. The worry extends to everyday concerns like work, health, relationship, impact. Like GAD वालों का ऐसा होता है जब सुबह उठते हैं तो they are like आज किस बारे में like it's a daily work for them. हर सुबह they are anxious about one thing or other. Now coming to this case 5, page 30-year-old female having somatic chest pain, palpitation, burping, following a panic attack with persistent fear of developing heart. Now this patient experienced.
Sir, it will be very kind of you to wind up. Okay. After some minutes, definitely.
Yeah, sure.
Yes,
Yeah.
yes.
This is the last case.
Yeah.
So the patient.
Sir, please unmute yourself.
Thank you. So this patient experienced a sudden and intense panic attack a month ago, and it was characterized by feeling of impending doom. And subsequently, she developed somatic symptoms like chest pain, palpitations, excessive burping, and they have persisted since the panic attack. The patient is preoccupied with the fear of having heart disease, leading to heightened anxiety. In all the the reports, everything is normal, and history otherwise is all negative. The diagnosis of panic disorder with somatic symptoms, specifically chest pain, palpitations, and burping based on DSM-5 is made. So, similar case, I won't go into it. So yes, so what is the hypertension and anxiety? The relationship is intricate and bidirectional, involving psychological, physiological factors, and hypertension and can exacerbate symptoms. And anxiety disorders are more prevalent in hypertensive patients, like 37.9% of hypertensive patients have anxiety disorders, while 12.4% in the general population have anxiety disorders. Anxiety can be a contributor to hypertension. Anxiety triggers the body's stress response, releasing stress hormones like cortisol, increasing sympathetic nervous system activity. Acute and chronic effects of anxiety can increase, like acute anxiety can temporarily increase blood pressure, while chronic anxiety can cause sustained elevated levels of blood. An unhealthy coping mechanism of patients with anxiety may lead to hypertension, like smoking, excessive alcohol consumption, which are again risk factors for anxiety. And hypertension can contribute to anxiety, like hypertension can have physiological effects on the brain and cardiovascular system, potentially contributing to anxiety. And some medication side effects, as you will see in the next slide, like beta blockers, potentially can lead to fatigue, depression, vivid dreams, and sleep disturbances. In some patients, calcium channel blockers can lead to headache and mood. ACE inhibitors can changes in mood and diuretics can lead to changes in sodium potassium levels, electrolyte imbalance, which can influence. And both can have shared risk factors like lifestyle, common sedentary behavior, poor diet and smoking, and some there can be genetic factors that also cause both of them. And it can impact the overall well-being, both of them. The coexistence of hypertension related disorders can significantly impact the individual's quality of life, leading to challenges in daily functioning and emotional well-being. And the combination of both these may increase the risk of cardiovascular complications and other health issues. Treatment implications, again, there should be lifestyle modification and collaborative coordinated care between mental health professionals and the healthcare providers for hypertension. So with this, I end my presentation. Thank you. Thanks for the patient listen.
Thank you very much, sir. It was very informative, and as you have shared the cases, so a very much practical overview of the topic. Now, I would request Dr. Mohini Apte, madam. She is Associate Professor in Indira Gandhi Government Medical College, Nagpur. She is a pediatrician, and she is will be presenting the topic on perspective of pediatric hypertension. I request madam to kindly share her screen, and she can go with the presentation.
So good afternoon, everyone. Can you hear me?
Yes, madam, we can hear you.
Okay. So,
Madam, you have to share your screen, and your camera is not on.
okay, I'm trying actually. Now?
Your camera is on. You can share your screen.
Yeah, just a moment.
Yeah.
Is it on?
No, madam.
I'm trying to share.
It's okay, madam. First of all, open your PowerPoint presentation in your laptop
It's
and
on.
minimize it. And minimize it.
Acha, okay, minimize it, is it?
Okay, you minimized it.
So I'm doing it on a tab.
Okay, okay, madam. Exit from the slide share view and then minimize it, the window.
Okay. So, but I should put the slideshow on.
Afterwards, then come to the Zoom meeting now. With that, click the option of share screen. That is the fifth option on the script that is coming up.
Okay, now I'll just check.
Come to the meeting.
Yes. And what do you want me to do now?
After sharing your screen will be visible to us. Then you can go back to the PowerPoint presentation and you can start the slideshow. So then we all will be able to see that.
Okay, just a moment. So I'm sharing the screen now.
Right.
But it's not opening. It's so it's not happening.
Okay, madam. Don't worry. We will make it in this way that I will share my screen and your presentation, and you will be talking from there, and then you can just say next, and I will change the slide. Okay.
Right. Great.
Just give me 2 minutes so that I can do arrangements for that. Right.
Right.
Okay, ma'am. Okay, madam. Now, can you see the your PPT?
Yes, I can see my PPT.
Yes. Now you can continue.
Yes. Thank you so much, and sorry about the trouble. So
No,
good
madam,
afternoon.
it's okay. It's all right. Don't worry. Just do your best.
Yeah, thank you.
Thank you.
So good afternoon, everyone. And today we are going to look at perspectives on pediatric hypertension. Now, since morning, you've been listening to speakers who are talking more or less on adult hypertension. So I thank organizers for recognizing the importance of hypertension in children, especially Dr. Shafi, who's my batchmate, and he's also the organizing chairperson of the CME. So thank you so much, Shafi, for inviting me to for this talk. And I'm very happy that the organizers have recognized the importance of awareness among people, because I see I'm talking to a very wide audience. Some of you are physicians, general practitioners, neurologists, and so on and so forth. So it's very important that people understand pediatric hypertension. So the medical services in this country are more therapeutic than preventive, and a person has to be sick to be for him or her to have access to healthcare. They seek access only if they have a problem, and then they just forget about it. So but it's slightly different in pediatric health scenario, because people are slowly understanding the importance of vaccine. Government is also doing its bit towards vaccination. So preventive care up to under 5 children is improving. But what remains is that after 5, when the vaccination is hardly there, people are not accessing healthcare just for checkup. And that is a very big problem. So vaccine has decreased the burden, infectious disease burden. There is improved sanitation. There is improved socio-economic status. And we are slowly moving from a country which was considered to be a capital of malnutrition to a scenario where you are having a population which is now thought to be the capital of diabetes. So just see the change from malnutrition, people dying of hunger, to people dying of other end of malnutrition, that is obesity. And that brings us to today's topic, that why is it important to know about hypertension in children. So now hypertensive children, although very infrequently they're symptomatic, they will have end organ damage just as in adults. Up to 40% of hypertensive children, when diagnosed, will have left ventricular hypertrophy, or as seen in adults, or even early signs of atherosclerosis. Hypertension during childhood often continues into adulthood, and children with BP of more than 90th percentile exhibit a 2.4 greater risk of hypertension as an adult, and therefore early coronary and artery disease and risk of stroke, and so on and so forth. Adolescent hypertension, it's a very big thing. It's an in thing, and it's also independent predictor of both end-stage renal disease and left ventricular dysfunction. Next slide. So childhood hypertension is also divided into two broad groups. That is the primary hypertension, just like you have in adults, and secondary hypertension, where there is an underlying cause or a disease which is causing the secondary hypertension. Next slide. So now in infants and children, the systemic hypertension is really, really uncommon. The prevalence is less than 1%, and when present, often indicates that there is an underlying disease process. The prevalence of primary hypertension, mostly in school-age children and adolescents, is now increasing, and it is this prevalence has increased because of the parallel increase in prevalence of obesity. That's the obesity epidemic we are looking at. So severer the hypertension, more symptomatic the hypertension in children, it is usually caused by secondary hypertension. So secondary hypertension means that there will be an underlying cause. A younger the child, more severe the hypertension, it is more likely that there will be an underlying cause. Next slide, please. So, and there is something called the phenomena of tracking. Now, the tracking refers to the pattern of repeated BP measurement. This is just to highlight that if the child has primary hypertension, he is likely to have, over a period of time, he will be hypertensive, and he will be hypertensive as an adult. And this has been seen under various long, the result of a long-term follow-up studies done in Western world. So if you happen to have a child who is hypertensive, then you need to follow these children and monitor them very closely, because they are the children who will need treatment. Because if you don't treat them and leave it like that, they will. So now, ब्लड प्रेशर मेजरमेंट इन चिल्ड्रन. सो किस में देखेंगे कि कौन से बच्चे हैं जिनके लिए आप सोचेंगे कि इसमें मुझे बीपी देखना चाहिए. सो फॉर चिल्ड्रन 3 years old, annually taken. So it's about older children, 3 years and older. This is all 2017 AP guideline. If the children has risk factors such as obesity, chronic kidney disease, or diabetes, it should be checked at every healthcare encounter. So every time a child who's obese or has had a kidney problem, need not be a chronic kidney disease or diabetes, he or she should have a blood pressure recording. Now, in younger children who are less than 3 years old, if there is a history of prematurity, congenital heart disease, renal disease, some drugs which the child has received which can lead to hypertension, or there are neurocutaneous stigmata like neurofibromatosis, tuberous sclerosis, or there is a evidence that child may have raised ICT, then these are the children who will require follow-up, and they will require blood pressure recording at every encounter with the healthcare professionals. Next slide, please. So I'm going to be very, very basic here, because see, every time pediatricians talk to non-pediatrician, they always try to highlight that children are not small adults. So to measure BP, we have to be very, very careful. The BP cuff, the sphygmomanometer and auscultation by the BP has to be measured by auscultation using a sphygmomanometer cuff of appropriate size. Now, why the appropriate size? Because if the cuff is too large, the BP will be less, and if the cuff is too small, the BP will be more. So either you will fail to diagnose or you will miss the diagnosis if you are not using a proper size cuff. Next slide, please. Next slide, please. So see, I have deliberately brought this picture here because the cuff size, if it is improper, you will find that your blood pressure readings are faulty. So a blood pressure cuff should measure, should cover 40% of the circumference at midpoint, that bladder of the BP cuff, and it should cover 80 to 100% of the arm. And what part, how do you measure arm? Arm is between acromion and olecranon, and you have to cover 80% of the length and 40% of the circumference. So that is an appropriate BP cuff. So after using the appropriate BP cuff size, next slide, please. Next slide, please. So this is the variable size cuffs. We see, I'm not aware, most pediatricians will also not have, but these are up for sale and not very expensive. So those of you who are seeing children in their regular practice, please have these various size blood pressure cuffs, because only then you are sure and confident that really the child does not have hypertension or does have hypertension. So next slide, please. So once you have taken adequate care for BP measurement and you've got a value, then you have to see whether this child has normal blood pressure, mild elevation of blood pressure. Is he in stage 1 hypertension or stage 2 hypertension? That is how hypertension is graded in amongst children. So now for children aged between 1 to 13 years, you will have normal blood pressure. That is, so we have centile charts for children. So you can Google it. They are available widely. So if your child is falling at less than 90th centile, then your child is has normal blood pressure. If that systolic BP for a less than 13-year-old is falling between 90th to 95th centile, you will have to keep a close watch on this child. Now, if this systolic and diastolic, in this child, if the systolic and diastolic blood pressure is between more than 95th centile or to 95th plus 12 for systolic and diastolic BP, or more than 130 but less than 139, it is stage 1 hypertension. Or if it is more than 95th centile plus 12 or BP more than 140, it is considered systolic and diastolic 140/90, it is considered as stage 2 hypertension. So you have to use centile charts for younger children. For 13 years children or older, it's like adults. So normal BP is systolic less than 120, diastolic less than 80. Stage 1 elevated is more than 120 up to 129. Stage 1 is 130 to 139, and more than 140 is stage 2 hypertension. Now, why we have the graded this hypertension is when we will come to the treatment, we will decide on how we are going to treat these children. So, next slide, please. So, once we have got a child who has hypertension, we want to know or understand whether it is a primary hypertension or essential hypertension, just like you have in adults, or it is like a secondary hypertension. So if your child is a prepubertal, so we have already discussed that the younger the child, more symptomatic the child, it is likely to have an underlying cause. So secondary hypertension is more common in younger children, especially if the child is less than 6 years of age. If it is a post-pubertal child, then you are more likely to have a child who would possibly have a primary hypertension. If there is diastolic hypertension, it is going to be a secondary hypertension. If it is nocturnal hypertension, it is going to be secondary hypertension. If the child is overweight, obese, there is family history of obesity, it's going to be primary hypertension. And if the child is presenting with headache, sweating, vomiting, tachycardia, left ventricular dysfunction, the likelihood is that it is a secondary hypertension, because secondary hypertension appears when there is a cause. And if there is a cause like a pheochromocytoma or like a transient cause like a post-streptococcal glomerular nephritis, then it has happened acutely. There is no time for the child to compensate, and therefore secondary hypertension will become more symptomatic even if there is a very mild rise in blood pressure. Next slide, please. So in children, etiology could be, it is not, since it is not essential, it can be renal, vascular, endocrine, and so on and so forth. Very important to understand is if there was antenatal diagnosis of polycystic kidney disease, dysplastic kidney, dilated pelvic alveolar system, or there was any evidence of obstructive kidney disease, because these are the children who will later, they may progress to have a very severe form of this condition and will have hypertension. So some of these children can be diagnosed even antenatally, because the problem starts in fetal life. Then you have other causes like VUR causing pyelonephritis, or younger children less than 1 year old have recurrent pyelonephritis. There can be chronic glomerulonephritis, primary or secondary, or there could be renal tumors, trauma, and so on and so forth. Vascular is a very important cause of hypertension in children, because renal artery lesions, mainly stenosis and fibromuscular dysplasia, are the commonest cause of hypertension in children. So if it is a congenital, if you look at coarctation of aorta, there will be a variation between upper limb and lower limb. The lower limb blood pressures will be higher and than the upper limb blood pressures, and that is how we come to the diagnosis. Umbilical artery catheterization, if there is a history in neonatal life, then obviously this can be the cause. Or in younger children who have suffered acute gastroenteritis and now they are having hematuria, it could be younger children, it could be renal vein thrombosis. Other vasculitis syndromes like polyarteritis nodosa, Takayasu arthritis, also known as pulseless arteritis, and ANCA-associated polyarteritis nodosa, and so on and so forth, can be diagnosed because the child has come to you with symptoms of hypertension. Next slide. So, continuing on the etiology, it can be endocrine. So, there are certain conditions called congenital adrenal hyperplasia, where the child has a defect in synthesis of hormones, and they primarily present as hypertension, especially if it is a 11 beta or 17 hydroxylase deficiency. There can be tumors of various types or syndromes like Little or Geller syndrome. Then a very very uncommon situation, but which presents with acute hypertension, is intracranial bleed or intracranial mass, where the child suddenly loses sensorium after a episode of acute headache. So this is most common is intracranial bleed. Next slide, please. So these were the causes of secondary hypertension, where there is some other problem in patient, and but the child is presenting like hypertension. So now there are certain transient hypertension conditions which can lead to hypertension. So that is why when you have a child whom you thought or whom you have measured and has a higher BP reading, or he falls into a child with hypertension, first and foremost thing you have to do is understand that whether it is transient or it is going to be progressive. So transient condition most commonly in children is drugs. Drugs being as simple as nasal decongestants or other sympathomimetic drugs. Some children are on amphetamines for conditions like ADHD or vitamin D intoxication and rest of the other things. But most important are these common drugs like pseudoephedrine containing cough syrups, though they are banned, but they are still available. Sympathomimetic agents which are nasal decongestant. Then there are certain conditions which affect the nervous system but can produce a transient hypertension. Those of you who have seen Guillain-Barré syndromes in your ICUs, you will know that they have autonomic dysfunctions and therefore they will have tachycardia, bradycardia syndromes, and even hypertension, which is so much so that they will need treatment. Then acute intermittent porphyria sometimes presents as acute abdominal pain with hypertension, and it is episodic. So it is not going to be sustained. When the child is well, he'll have normal BP. When the child is not well, he'll have hypertension. So all those conditions where there is autonomic dysfunction can have hypertension. Then post-streptococcal glomerulonephritis is a very relatively common condition in pediatric wards, where you have a child who has suffered from skin lesions or sore throat, and then he presents with high colored or cola colored urine or red urine, that is hematuria, hypertension, edema, and that triad is your glomerulonephritis, which is a self-limiting disease. The child is going to be better within 3 months. Henoch-Schönlein purpura has a peculiar rash. It is a vasculitis, but it will improve within 3 months' time. So then hemolytic uremic syndrome, like situation where you have the child has preceding history of diarrhea and then suddenly becomes sick as he is recovering. And this diarrhea is very classical. That means there is a blood in stools. That means dysentery. So E. coli diarrhea or Shigella diarrhea, EHEC or Shigella type 1, which is a positive organism in this for this dysentery, and which in some children will lead to hemolytic uremic syndrome. The child becomes pale and develops all parameters of renal dysfunctions. So it can be drug-induced acute kidney injury, it can be infection-induced acute kidney injury as seen in malaria, and many more such conditions. Next slide, please. So we have looked at various causes. So hypertension can be primary, it can be secondary, it can be transient, or it can be progressive. So when we are evaluating a child with hypertension, we have to take a detailed history of what was preceding event, what happened before the child presented with these symptoms of hypertension, whether there was history of any sore throat or impetigo, as we have discussed just now, or dysentery, whether there was history of any fall and head trauma, whether there was any rash, joint pain, joint swelling, whether there is a sensory neural hearing loss in this child, what were the medications the child has received recently for whatever reasons. It could be simple URI for which he was prescribed pseudoephedrine or nasal decongestants, or it could be or this child who is presented with hypertension. You have to take history of whether the child is passing, what is the color of urine, what is the amount of urine the child is passing, to understand whether he is having hematuria along with raised blood pressure, or whether there is any flank pain which can suggest renal stones. So depending on what, other than hypertension, what is the background history, and what are the other symptoms the child is presenting, the child, you can narrow down on at least the symptom or system of the affected system which is causing hypertension. So if there was a head trauma, probably there was intracranial bleed or a contusion, raised eyes, followed which there is cerebral edema, and therefore the child has now hypertension. So a background history, background medication history, some developmental problems, family history is very, very important, especially if there is a history of hypertension, renal disease, obesity, or MI. Hypertension is important, especially if the family has hypertension. Rarely I find that sometimes we have newborns who are accidentally diagnosed with cystic kidneys, bilateral cystic kidneys, and when we screen their parents with an ultrasound, we find that they themselves have cystic kidneys. So it is a ADPKD, that is autosomal dominant polycystic kidney disease, or ARPKD, which is a autosomal recessive polycystic kidney disease. So in both, the family history can be positive. So if there is a family history of hypertension and there is a young child presenting with symptoms suggestive of hypertension, you have screened, please take a detailed 3-generation pedigree chart to know whether this is a genetic condition. Obesity runs in families, and early MI, death in a family in less than 55-year-old, this is the old definition, with cardiac illness, you have to screen this families, adolescents at least, for hypertension. Now, birth history, if there is, this is pediatricians' forte, they keep asking history about everything. So now birth history becomes important, especially if there is an IUGR. Now there is something called Barker's hypothesis or a thrifty gene hypothesis, where because this child grew in an environment for whatever reasons, mother may be hypertensive, she was diabetic, she had paracental vasculopathy, or whatever was the reason, this child grew in an environment, fetus grew in an environment where he had to conserve everything. So this gives rise to a peculiar metabolism in this child who after birth, when given normal nutrition, still the metabolism is thrifty. Thrifty is conjuice. So it goes on saving everything. And this child is ultimately going to be obese, will have extra fat stores, will develop early atherosclerosis, and will have early, so the hypothesis is called as early markers of in children for adult disease. So if the child had IUGR, it was a premature baby who required umbilical catheterization, here you have a cause which has led probably to this hypertension. Growth history is also very, very important. Generally, children with chronic kidney disease come to us for not for kidney problems, but they come to us for not gaining height, for knock knees, bow legs, because they have developed rickets, which is secondary to renal dysfunction, or they have just chronic growth failure because of the chronic disease. Next slide, please. Next slide, please. Previous slide. So it is important to measure weight, height, BMI. There in examination there will be a lot of clues. If you have upper limb pulses which are good but lower limb pulses which are absent or weak, it could be coarctation of aorta. Then it could be peripheral pulses are weak all over. It could be like vasculitis syndrome, like pulseless disease or Takayasu's arteritis. So a good examination in a child who presents with hypertension is very, very important. You can have mooning or moon faces in child with Cushing syndrome. So Cushing syndrome is nothing but excess cortisol in the body, which will lead to hypertension. There can be goiter and child may be hyperthyroid and therefore will have hypertension, or tonsillar hypertrophy leading to obstructive sleep apnea and therefore causing hypertension. A good eye exam. Once you have diagnosed hypertension in a child, you have to do a complete examination or get checked by a ophthalmologist for any retinal changes or papilledema. A skin rash, which is has peculiar distribution, like in SLE, where a post-pubertal girl presents with a peculiar butterfly rash over face, and hypertension and some mouth ulcers, you have a child with SLE. There could be cafe au lait spots, multiple hyperpigmented spots in less than in pre-pubertal age they are small but multiple. In post-pubertal age they suddenly increase in size. So if you have hyperpigmented patches, your patient possibly has neurofibromatosis, which can cause hypertension because of a malignant space occupying lesion in brain, or because of renal vascular causes. Now, genitally, as we have discussed, congenital adrenal hyperplasia is a very rare, but if the child with hypertension has ambiguous genitalia, you have to think of congenital adrenal hyperplasia as one of the cause. Abdomen may present with renal mass in a child with hypertension. So it could be a tumor like Wilms tumor, neuroblastoma in younger children, or any other like a rhabdomyosarcoma or something like that, presenting as hypertension. There's a renal mass. So there's so many things which can happen to a child, but a good history and a good examination in a child whom you have found that the blood pressure is high can give you a good insight into the cause of hypertension. Next slide, please. So once you have documented, so this is a brief algorithm. So once you have documented hypertension, it is mandatory to take blood pressure in upper and lower limbs. If there is discrepancy in upper and lower extremities blood pressure, you have possibly a patient who has diagnosis of coarctation aorta. If it is not there, the blood pressure is same in both upper limbs and lower limbs or within the normal physiological variations, you have to do a urine analysis and also a renal function test. If urine analysis is showing most of the more of pus cells and organisms, it is possibly an infective etiology like pyelonephritis, reflux nephritis, or recurrent urinary tract infection, or any other renal anomaly like a VUR, vesico-urethral reflux. If it is a predominant red blood cells like hematuria is the predominant presentation in urine analysis, then probably you're looking at renal vein thrombosis if the child is young. It could be a tumor. It could be a simple self-limiting post-infectious glomerulonephritis. It could be a chronic glomerulonephritis like in lupus. Or if the child has peculiar rash which has presented only on buttocks and lower limbs, probably it is Henoch-Schwann purpura. So depending on a small first finding of high blood pressure with no upper limb, lower limb variation, with a simple test like urine routine and a KFT, which will tell you whether the renal function is normal or not, you can reach the diagnosis of primary hypertension. If everything else is normal and the child has only high blood pressure, or it could be a renal vascular cause or endocrine cause where everything else is normal. But you have to keep searching till you have searched in all systems. If everything is normal, then by default your child has a essential hypertension. Next slide, please. So management. Now, once you have diagnosed your child who has hypertension, as the first dictum I said, if the child has come with symptoms or a very severe hypertension, or there is presence of end organ damage, then you have to treat immediately. Now, in children with elevated blood pressure who non-pharmacologic therapy, example diet and exercises, is initiated to reduce the blood pressure. See, we had 3 grades: elevated BP, stage 1 hypertension, stage 2 hypertension. So in elevated, so who are above 90th centile but below 95th centile, then we first start with non-pharmacologic therapy. But if the child has hypertension but there is no end organ issue, then you have to treat first with non-pharmacologic therapy, and if that the child is not responding, then maybe pharmacologic therapy. But if the child has stage 2 hypertension, then you have to treat with both upfront. So patient with stage 2 hypertension, sometimes or more, as it is called as malignant hypertension, who present with headache or altered sensorium or other neurologic finding like stroke or press, as some speaker was talking about in adults. So children also get press, or sometimes the children present with acute left ventricular failure because the heart is unable to pump against a very tight blood vessels or aorta. That is the because of the loss of elasticity that happens in acutely hypertensive child, and then suddenly child lands in hypertension, and then suddenly lands in acute left ventricular failure and pulmonary edema. Now, if diagnosed, these are very gratifying to treat, but they have to be treated in ICU, and this is beyond the scope of this talk. So we will just talk about children who have elevated BP, stage 1 or stage 2 hypertension. Next slide, please.
Ma'am, it will be very kind to wind up in few minutes.
Two slides maybe.
Okay, madam.
Next slide, please. So if the child has secondary hypertension, we have to treat underlying cause. If suppose the kidney disease is there, then the child will need both non-pharmacologic and pharmacologic therapy for blood pressure and also for his kidney issue, and same with the diabetes. Next slide, please. Next slide. Next slide. Slide after this. So we have to target the blood pressure management approach is that we have to first decide how much the blood pressure reduction is required. So for so the target, since there are no studies on this and how much is good enough, so we have to follow 2017 AAP guideline, which says that the systolic and diastolic blood pressure should be below 90th centile or below 130/80 in adolescents or 13-year-old or more children. Okay. Next slide, please. So I would like to insist on non-pharmacologic therapy, or rather non-pharmacologic prevention of hypertension in children. See, you can't ask children to lose weight. You can't ask children to not eat fats. You can't, but you can moderate their diets. See, myelination is going on, so fat-free diet or something like a keto diet cannot be advised to children. So it has to be a moderate reduction in calorie, moderate reduction in salt intake, regular exercise, restriction of sedentary activities. I'm sure all of you have seen children with tabs, mobiles. which has not put them into couches, chairs, beds, and move them away from playgrounds, physical activity, and this is what is causing the biggest problem today. So regular exercise, and adults have to do a modeling. We call it social modeling. That if you exercise, your children will exercise. If you eat healthy, your children will eat healthy. If families are eating chips, kurkure, and with a very high salt, and sitting on couch watching movies, so this is not how you. And then after some time, when the child becomes obese, you tell the child, ab ye mat khao, ab wo mat khao, but he has seen everybody in the family do that. So the good social modeling is very, very essential. And just like charity begins at home, similarly a non-hypertensive lifestyle begins at home. So dietary modifications are required in children with hypertension. The DASH diet, as was discussed. So high intake of potassium, lot of fruits, and fresh fruits, vegetables, lot of salads. Snacks should be fruits and low-fat dairy products. Ghee, makhan has to be avoided. So non-pharmacological measures to reduce cardiovascular disease risk factors are very, very important. Lipidemia, chronic syndrome in this includes and so on and so on. Next slide, please.
Yes, ma'am. Please wait. Some people have got unmuted. Okay.
Yeah. Yes.
Yes. Yes, ma'am. Yes, ma'am. Okay, ma'am. You can continue.
Right. So teens these days, I have seen teens these days drinking cokes, shakes, alcohol, and what not. I mean, children between 14 to 18 years of age have developed habits from where we don't know, but then yes, with media, with social media, with media, movies, videos, all wrong kind of propagation is being made. All these caffeinated drinks, energy drinks are propagated. And another place where it is propagated is the gym, where they ask you to take high protein diet, high protein shakes and whatnot. So all they have not been studied, and it is strictly recommended not to let your children get into these kind of habits of drinking uh, caffeine induced products like cold drinks and coffee of various types. It is really not recommended. I'm sure there will be studies coming up in soon which will show how harmful these things are. Next slide. Next slide, please. So pharmacologic therapy will be needed in children with stage 1, in which dietary and say, avoiding sedentary lifestyle, prevention of weight loss is not working. So the target, as we have already discussed, will have to be achieved by starting the lowest dose, lowest effective dose, and then progressing to increase the dose and adding another drug if required. But first and foremost will have to be compliance, which has to come from the parent as well as, see, as soon as we tell any diagnosis like hypertension or diabetes in children, the parents first thing they'll do is leave allopathy and try to move to some other pathy. So I believe that counseling needs to be done, that you try everything else, but please stick to this diet restriction and pharmacologic therapy while you try and work. child. So I have started doing that. So as soon as we give a grave diagnosis, people will just leave. So first thing I counsel that this whatever your condition is will require chronic therapy, but your child will be better. If you want to use other therapy, please continue this therapy. Do not stop medication. I've had type 1 diabetics coming with hyperglycemia, DKA, after stopping insulin just because somebody told them कि छोटे बच्चों को diabetes हो ही नहीं सकता, छोटे बच्चों को BP हो ही नहीं सकता. So all this goes on in society. So you have to counsel practically. Next slide, please. Next slide, please. So there are various drugs which are, as already discussed in previous lectures. So first line that antihypertensives are ACE inhibitors. We do not diuretic. They add to hypokalemia, glucose intolerance, weight gain, especially in obesity. So ACE inhibitors and angiotensin receptors blockers or calcium channels blockers are our primary drugs we start in children with hypertension. Next slide, please. Underlying cause, you need to take the change. Next, please.
Madam, please wait, madam.
Please unmute your mic.
कर दिया मैं. Yes, ma'am, you can continue.
So next slide.
Yeah. Okay.
Yes.
Yeah.
Previous.
Okay.
So you can see this UNICEF data, which is showing that 1 in 10 obese children globally will be from India by 2030. 2030 is not very far, and we have to be aware of this, of the risk. And these are our children. These are our children in our home, our relatives. So we have to monitor diets, activity of our children, and only then. So hypertension, secondary hypertension, will remain, and it because there is an underlying cause. But this obesity pandemic is going to bring in a new hypertension pandemic in this country, and which can be prevented if all of us are aware of what food we are eating, what food our children need to eat. Our grandparents in homes need to be just let down a bit, not khilao kheer, puri, halwa to our children. And promote healthy lifestyle, less screen time. There are so many guidelines on screen time for children. We have to propagate it. It is imperative that we do it. Otherwise, we'll have a obesity pandemic and therefore a hypertension pandemic. Next slide, please. So we are just coming out of one COVID pandemic. I pray that we do not land in another. That is the obesity pandemic. Thank you. Next slide. Last slide. Thank you so much.
Thank you very much, madam. Thank you. Madam, as you are a distant speaker, our director, Dr. Shafi sir, would like to present you the memento that will reach to you in a few days.
Thank you. Thank you so much, Shafi. Thank you so much.
Thank you. Welcome. You are most welcome.
Thank you, madam. Now I call upon our sorry. नहीं मैडम को ओपन किया था I would like to call upon our next speaker who will be talking on lifestyle modification, the most important part in hypertension, Dr. Mansi Padhyagurj. She is a professor and head of Department of Community Medicine in SMBT College, Nasik. Madam has done her MBBS in distinction in FMT. She has pursued her MD with the first rank from LTMMC Sion College. She is diploma in public health and she is UGC and also done UGC and net qualified for her lecturership. Madam is having a huge experience of teaching, almost of around 18 years. She has 26 publication in her name and ICMR 2 projects and UNICEF 1 project. Madam is a resource person for research methodology workshop and medical education unit workshop. Madam is having a huge list of special achievements that she have scored 96% in ICMR, scientific writing in healthcare research, and many much. She is a member of IAPSM and Indian Medical Association. With this, I would like to call upon Dr. Mansi Madam to kindly share her screen and start with her presentation.
Hello, good afternoon. Thank you,
Yes,
Dr.
good afternoon, madam.
Yeah, and thank you very much, Dr. Shafi, for inviting me for this August gathering, a talk to this August gathering. I'll just try sharing my screen. Let's see how it goes.
Okay, madam. Yes, madam, we can see your PPT.
Yep.
You can move to the slideshow. Yeah, you're
This is the
all
slideshow
set to
now?
go, madam.
Right.
No,
Okay.
you're all set to go. Madam, just please a humble request to concise the topic.
Yes, yes, very much, very much.
Yes.
Because as the topic given to me is extremely general topic, and
Yes.
I suppose since morning everyone has been talking a part of it. So
Yes.
I don't think more elaboration will be needed on this.
Yes,
So
yes.
I have been told by Dr. Shafi to talk on diet and lifestyle modification and hypertension.
Madam, just one interruption. After your talk, we will take the screenshots. So we are waiting for delegates who have not joined yet to join. Okay, so we will wait for your talk. Okay. Thank you, madam. You can continue.
Yep, thanks. Now, as you see, I am from the Department of Community Medicine, and in community medicine, our primary concern is to tell medical stuff to people who cannot understand English, first of all, people who we have to speak in their local language and see to it that they understand complex things, and especially primarily which is related to prevention. So with that objective, I assume that all of the people over here, all of you who have gathered over here, are practicing medicine in some format. So I'm going to talk to you as if how should you approach your patient with all the things that you have learned today and all the things which you already know. How should we approach people and tell them this and get it into practice? So for that matter, you can start it with practicing for your own. So just see if you can apply whatever I talk to your own and see if you can advise this to patient in the format in which I tell you. That is my basic purpose of this session. The purpose of this session is hardly any dissemination of knowledge, because I think since morning it's been done to a great extent. So now I will be concentrating how you will disseminate this knowledge to your patients in a language and a pattern and a format in which they understand. So with that, I'll start. All of us are working professionals, and this is something which all of us have been struggling. Work life balance are very keywords nowadays, and everybody talks about them. How do we get that, and what exactly does that mean, is something which I'm going to talk now. Now we have coined at SMBT, we had this session on wellness, and we have coined this very simple term. Let's not go into any jargonish thing and talk things which are not understood by laymen. Let's talk about something which people will understand. So wellness is a concept. Wellness is a choice of lifestyle, and it is marked by a balance of mind, body, and spirit. Now you'll say at one point I'm talking about simple language, but this sentence is so profound. Balance balance of mind, body, and spirit is a very profound sentence. So let's see how we can talk about it. One thing which I want you all to understand, that this is a choice. So you can make this choice. You are in a position to choose this. You are at the role of decision maker in your own wellness. I'll give a half a second to all of you. This is a very simple chart which you can use in your OPDs, especially when you are treating patients with hypertension, or like in the previous session we saw pediatric hypertension. So people you need to screen and start early diagnosis and treatment at the primary and secondary level of prevention when you want to work. You can give this simple chart to your patients and tell them to make a web of this sorts. Now here 1 is the best number and 10 is the least mark. So you might have one individual who says that, okay, at the intellectual level, say you have got a very, intellectual person who is working in IT sector. So he might say intellectually, you have to come to the center. Center is the best mark. So he will say, I am at the level of 2. I'm doing very, very well intellectually using all my academic strength every day. However, the person might say, I am very poor socially because I'm so busy, I hardly get any time. So, on this level of social well being, I become just 8. Now, at the same time, the person might say, okay, my emotional quotient is not that bad. And so, emotionally, I might say I'm level at 5. Exercises, I hardly get any time. However, I still find around 2 times a week to do. So, I'll say I'm 6. I'm very, very poor on sleep because of my late working hours, and I'm working with people in the US at their work days, working timing, and so my sleep patterns are extremely poor. Nutrition, somehow I am managing to survive to have good nutrition. So, this is a pattern which has come out from this particular person. You can give this type of a graph, which can be called as a simple thing called web of wellness, and tell them to jot them down yourself. So now you know which areas are weak. See, if you attain all these areas at one go, you are going to be well. Wellness is what? Wellness is just using your intellectual capacity, be good socially, have a good emotional quotient, exercise, sleep, and take care of your nutrition. That is wellness in a nutshell. So you will get an idea where the patient stands. The patient gets an idea where he or she stands. And this is a very simple technique which might help you in the OPD. So basically, you have to tell your patient that the patient has to come to a balance between body and mind. When that is achieved, wellness is going to be achieved. Anything goes wrong, something goes wrong with your mind, it goes down. Something goes wrong with your body, the body graph goes down, and wellness will not be achieved. A complete balance is actually what we mean when we say wellness. So, we had, like I defined coined this term that when should I say that I'm all right? When should I say that I'm all well? I personally believe that I say that I am all well when I can get through my day with enough energy for work and enough energy for play after my work time. So I personally feel that we can define this simple thing to our patient, that if you get on through your work in the best possible way, you are not getting overtly exhausted. You have enough energy to come home, work, play, take your children's studies, to spend time with your parents. Then I think you are supposed to be well. Now, what happens is wellness now has very weird type of sort of landmarks which is created by social media. And someone feels that having a six-pack is well. A person who can run a marathon is well. But I really do not believe so. I believe wellness is when we can get through our work with enough energy for work and play. That should be defined as wellness. And this is what we should tell our patients. Nothing else matters other than you yourself feeling good about your own day. Now, exercises. So we sit in the OPD and we tell the patients, exercises chalu karo, just as if we are prescribing PCM to the patients. So this is actually never going to work out. They are never going to know what to do, or they might suddenly start doing something and fall more sick, injuring their own ligaments and bones in the process. So exercise can be explained to your patients in four type of exercises. The first is the cardio. Now, cardio is any exercise in which you listen to your heartbeats. So it could be just going up and down the stairs. It could be going out on a walk on the road or in the park. It could be just stepping up and stepping down on the stepper, which is at home, or using a treadmill, or skipping, or whatever that makes you feel. Listen to your own heart. That is, the heartbeat should not be because of fear. Obviously, it should be because of physical exercise, and that can be termed as cardio. Now, walking, running, jogging, stepping, climbing the stairs are the easiest, cheapest type of cardio that can be done. The only thing that you need is a good, comfortable pair of shoes. Even the ones which are really not very expensive branded one, but flat, soft ones fit the purpose. Second is strength training. Now, here is the big issue. This is something, as many studies indicate that Indians are very low on proteins. This is also something we do not look up to. We think strength training is for all the gym people, for the people who pick up weights and all that. And women, khas karke women, are very very reluctant. They feel okay, they will start developing muscles, and then they will start looking manly. And this is not for me, this is for men. No, 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 no. This is for everyone. Everyone should have strength in their muscles to carry their own body weight. We all have to grow old in such a way that we can pick up our own groceries. We do not worry about how to get the vegetable bag at home. We should be doing our own work on our own without any extraneous help till the day of our death. That should be our actual fitness. Having six pack and not running marathon should be our actual aim. And this has to be taught to the patient that weight is very important. Not need just take 1 liter of fill them with the minor stones. Then you really need spend now, again and again telling this is because I deal with patients who are really financially off. They tell them something that they like a patient so that babies. The first thing she told me was हमारे घर में धूप ही नहीं आती, because she was staying in a very intense strong slum area. She never got to saw sun outside her house. मैं कहाँ सुखाऊं? So I had to give her other alternative options. So I'm talking in with these type of people in mind who actually need help. Stretching is another very excellent exercise. Just stretch all your muscles, uh, because that's going to give relief to all your aches and joints, joint pains. And last and never the least is balancing. Everyone should indulge in some sort of balancing exercise. Simple balancing. I think if you Google just words, 10 number of charts will come. So you have to just pick up the right one for yourself or for your patient. You should, if there is a physiotherapy department around, or you're in a position to explain them to this you have to be explaining with some icy material in hand. So balancing is extremely important, because as our age grows, as we lose our strength, we also lose our capacity to balance. So this is the slide which I lingered upon the most, because this is one very very doable thing. And when you start talking about this right from childhood, as Dr. Apte has mentioned, this will lead to a lot of prevention. Dr. Apte also mentioned that children are going to learn by observation. So you do this, your kids are going to do that. So for your healthy future and your next generation's healthy future, you have to do this. The simple things which you can talk to your patients in their OPDs. Suppose your patient is not at all interested in a structured activity like this, and khas karke this should be for small children, where you are not in a position to tell them to pick up strength, like pick up weights and do stretching. They might just not indulge into it. Might not be even safe to tell them to do that. So sports is one of the best thing to do. Sports, cleaning the house, men and women alike. should be taking part in doing this rigorous activity. It has got so many side effects of cleanliness also to it. So non-structured exercises are a big yes. Dancing is one very good exercise which you can tell to your kids. And these are all cardio activities. Sports, dancing, and intense cleaning can be very good cardio activities, good for your heart, and so many additional benefits. Now you must have realized that after you have a small walk, after you clean your house, you feel very happy. Obviously, you feel a bit tired, but then you feel very happy. And there's a basic science behind it, which I am very much aware that all of you are already knowing. It is release of happy hormones. And the happy hormones are dopamine, oxytocin, endorphins, and serotonin. Dopamine, the reward hormone, you feel good. Okay, fine. I did this. I walked for 20 minutes today. Good. Love hormone, you feel happy, good for your married life, good for you as a parent also, and a doctor too. Calmness, okay, you feel okay, things are in your control. Yes, things can happen, things are not haywire. And the power hormone, okay, I do have the capacity of doing this throughout the day, so that's nice. So, this you should be explaining to your patients that once you do exercises, this is what is going to happen to your body. Next aspect of wellness or lifestyle modification is nutrition. Now, nutrition has got so many theories behind it. So, you have got people telling you eat only twice a day. Then people will tell you eat after every 2 hours. So, then somebody will come and tell you, no, okay, just cut off all the carbs. Don't give any heed to this balanced diet chart which has been going on for generations, where they tell you to eat the base of the triangle should be of carbs. Just don't do that. Just eat a lot of proteins, and your fat will all be lost. So please do not promote this type of just do not promote this type of nutrition and things for yourself as well as your family and for your patients. The This particular nutrition triangle is one of the golden triangles and should be followed to the hilt. The proportions which they have given are time tested, used by our ancestors, and they have survived for a very long time. So I think we should be following that. In addition to that, what we should be following is mindful eating cycle. Now, mindfulness is something which I'm going to talk later on. So let's see why you're eating, when you're eating, what you're eating, how standing, sitting in tension, in relaxed mood, how much sitting with a big gallon of popcorn in front of the TV, is this so where you are eating, on the couch, on the dining table, where everything is going to matter. So develop good practices, have common food area, let everybody sit over there, finish off your meals in some 20-30 minutes. Do not go on eating again and again and again. Again, energy dense foods, if you follow this is going to be taken care of. And please do not go for any type of fads. Diet fads are extremely difficult to control. We have had so many Miss Indias. Like there have been people who will be off milk and milk products and poultry for a long time, and then they will have this all sort of calcium deficiencies and osteoporosis before they even turn 30. We have got n number of people who are dying in gyms because of doing unregulated exercises. Eating protein bars is something which again the previous speaker has mentioned. So we have to be very careful as to what we put in our mouth. And remember, whatever has been going on for ages, whatever our generations of grandparents have done and lived till the age of 80 and 90 is something which should be followed. That's very logical to do. Now, sleep. In that web, we had seen one aspect was sleep. Now, what happens is we are really underestimating the power of sleep. We should be getting sleep, and these are all the gadgets which have helped us to feel that sleep is no way important in life. And when sleep will cure half your issues, it will make you healthy. And this has to be emphasized when you talk to your patients, when you manage or prevent their hypertension. So, create a healthy work life balance, spend meaningful time with your family and friends alongside work priorities. This is again a very underrated thing. I assume that spending time with family and spending time with friends is our tonic to us. It gives us new life, it gives us vigor, it gives us purpose, it gives us so much of happiness. So this should never be underestimated, and this has to be a culture which has to be started in your children by you. Now, current stressors, all we have got so many students in our colleges who are having student debts. I can just imagine their predicament, like how they must be, how they struggle, how they run around for their scholarships. So this starts from very early stage in life nowadays, especially in medicine career. So this is one thing. Another thing is this: we just had Mr. Mark Zuckerberg apologizing to parents in last 2 days, saying that whatever my Facebook and Twitter and whatever what else he owns has done to your children is bad, and none of you should be suffering from this in life. He made a public apology, and the U.S. law Senate members were grilling him like there is no end. Like I was like surprised the way he was grilled. Such a rich man, such a powerful man, but then he had to answer for whatever the social media has done to the current generation. Now, I would also say I would grill Mark Zuckerberg on whatever the social media has done to my elder generation also, because I have got children who have better control on the mobiles and the this thing, and I have got senior citizens who are totally addicted to this. So no one of us is. So we, and this causes a lot of stress, because there are always an image that you want to project. There is always something who makes you very nervous, and then this doctor addiction and pollution. I will not go into details of that, but these are destroyers of entire families, and they are destroyers of civilization. So this has to be explained. Pollution is something which I really don't know how we as citizens are going to handle this. Cities are becoming more and more polluted. Like it's very easy to say start using the local transport, public transport, but then not very easy to do at many of the levels. But yes, these are rising concerns. So whatever we can control, we should be controlling. Then many of the things are just not in our hands to control anything. When we were cavemen, there was this fight or flight reaction. All these cavemen, when the tiger came, they had this either you fight it or flight it or you run away. What happened is the tigers went away in the jungles or got restricted because of us. We have become like now we do not face tigers. Obviously, when we encroach in jungle areas and build our houses, we do see them frequently. But we have still not, we are still struggling with this fight and flight. So whenever we are in that fight and flight, so exam to be given in the morning becomes like a tiger for us. So we feel as if it's a tiger, it's going to eat us up. We have got n number of quota students hanging themselves in and day out. Last few months have been very bad for our country's youth, the way they are hanging themselves. So this, and what happens is whenever you are in this fight or flight, for example, taking this session, now I'm very nervous. Okay, I'm late. I have to sit over here. Okay. I have to prepare Dr. Shafi away. Otherwise, call me and tell me why are you not in time. So we have to realize that these are not tigers. They are not going to kill us. I might just say sorry to Dr. Shafi and be there and start my session anyways. So we have to recognize for what we have to be take stress. What should stress us? And all these things happen in our body when we get stressed. Thickening of the blood happens, and that is one of the most important precursors of your hypertension. And this is how stress affects us. Emotional wellness, trail of thought, you try to be in the present tense. Now, what happens is if your child doesn't come in time from school, then you are worried, oh my god, कहाँ है अभी तक बस में बैठी होगी कि नहीं पता नहीं कोई I hope she has not met any idiotic people on the way. Oh my god, I hope her cycle has not met with an accident. And then ting tong, and the child comes and the child says the sir took extra class today. So it was as simple as that. But then this entire train of thought which started, that cycle का accident हो गया बदमाश मिल गया हो गया रोड पे उसको, it just doesn't stop. So we have to train ourselves and our patients to get rid of this train of thought. Live in now. Tomorrow is yet to come. Yesterday has already gone. So why bother? Just live in the present. Just at the moment is something that you have to talk to your patients and practice yourself. So mindfulness is something which is going to help you be in the present. Do not think of future to a great extent. Do not think of past to a great extent. Live now. Enjoy your life now. My God, this is the biggest stressor of the current generation, I suppose. Update, and update continuously. Right from your phone to your laptop, every gadget that you have held in your hand is going to be updated. Every software gets updated, and you have to. And you are over here today also for a session of update only. So update involve its intellectual wellness involves your ability and use in the knowledge. So as it is a necessity of life in future, why not enjoy it? Be over there, do it. So update is absolutely essential. If we do not update, we might be in a stress of different sorts. So again, we have to decide how much do we need. How much should I? Every Sunday should I go on attending a webinar? When am I going to spend time with my child? If I do not attend webinars, what's going to happen to my current knowledge? So we have to ourselves have our balance into all this. And then yes, there is, as I said, there is nothing like having a good half an hour with your child. Say even watching Shinchan or Doraemon will do, and spending some time with your friends, gossiping about your old days, some time with your mother, just listening to her talking about her old days. And this has to be there. We have to include everyone: short, tall, fair, dark, religion, caste, creed, disability. Everyone should be a part of our life, and we should respect everyone's presence. So that is a social wellness thing that we need to talk to our patient. So all of you just think of one activity that you love the most. For some, it might be singing. For some, it might be painting. For some, it might be just watching a series of television. So such an activity gives you a perfect balance of body and mind. When you're not thinking of your future, you're not of your past. When you do that activity, could be cooking, could be cleaning for someone, could be just folding clothes, could be anything. But one activity you have to find out for yourself, which you will do every day, during which you will be completely in your present tense. That will give you a perfect balance of your body and mind. Will not think about your past nor your future. Live behind all your worries and just be involved in that activity. One such activity per day is absolutely essential. So, just to summarize everything, let's talk about something which we can do really do every day. Maintain a gratitude diary. Thank the superpower to whom you pray for everything good that has happened today. Obviously, everything good might not have happened that day. So pray for a better tomorrow. Do one act of kindness, just bringing a glass of water to your mother, whom you know now she's going to get up and drink water. Picking up a pen and giving to your colleague. One act, one countable act. Keep a diary of that. Post lunch, post dinner walk every day. पोस्ट लंच तो कोई कॉलेज ना नहीं बोलेगा, कोई हॉस्पिटल ना नहीं बोलेगा. 10 मिनट अगर कोई बंदा चला कॉरिडोर्स में तो माइंडफुलनेस, स्टार्ट माइंडफुलनेस. चलो फर्स्ट सिप ऑफ वाटर, पहला निवाला जो खाते हो, पहला सिप जो पानी का पीते हो, उसमें पूरे कंसंट्रेशन के साथ पी के देखो. प्रोफेशनल स्किल, जैसे आप अभी अपने आप को अपडेट कर रहे हो थ्रू दिस सेशन, गेट वन स्किल फॉर योरसेल्फ. Smile at everyone, wish everyone whom you know. Obviously random smiling will make you feel like you bad, but wish people, smile at them. Just a simple act of acknowledgement of meeting after 12 hours. This is one thing which I really believe into it, that dear God, grant me ability to accept things that I cannot change, courage to change things that I can, and wisdom to understand the difference in the two. The best thing that we can do for our own wellness and maintain our hypertensions. So contribute to healthy environment, engage in physical activity, good nutrition, healthy work, mindfulness, and wellness for the community. A greater good is going to help you to a great extent, and your patients. So thank you very much.
Thank you very much. Thank you very much, madam. Since last 5 minutes, I've been trying to tell you, okay, madam, please wind up. But you are so enthusiastically and so beautifully speaking, said I could not interrupt in between.
Oh, that's very kind of you. Thank you.
Yes, thank you.
Could
thank
have
you
still, because no speaker should overshoot timing is something.
No, madam. No, madam. You were very, very enthusiastic and very beautifully. Dr. Shafi sir would like to present the memento to you, so that you are a distant speaker, and that will reach you in 2 to 3 days.
Thank you, sir. Thank you so much. Thank you, Shafi.
Thank you very much, madam. Thank you very much.
Madam, can you end your screen sharing so that we can continue with the session?
Sure.
Yeah. Okay. So we will be taking screenshot for the attendance. So kindly open your cameras. Okay. And as madam said that we all have to keep on smiling. So many smiling faces.
Just
Okay, thank you everyone. I have taken the now moving towards our last session, and very important. We have learned up till now what we should do, what are the treatment modalities, and what should be done, the lifestyle modification. But how to prevent? So coming to let me share my screen. Coming to our next very dynamic speaker. Yeah, Dr. Priya Prabhu or Dr. Priya Deshpande, madam. She is presently Associate Professor of PSM in Government Medical College, Miraj. Madam is having major achievements as project coordinator and master trainer in WHO pilot project for India, HCP preparedness for VAW in GMC Miraj. She is actively involvement in subject module creation for PSM. She is extensive scientific content creator, over 700 plus articles, 330 plus videos, 30 plus online and offline talks for the healthcare awareness. Madam is also having a blog of www.askdrpriya.in. She is having a book on drop of nurture, and she is co-author in that book. Madam is being honored and awards that madam has received is of Lokmat Sakhi Samman Pushkar for health sector 2022, CEHAT research fellowship 2022, Dr. PSN Reddy oration in state IAPMC PSM conference 2022. She is executive member in Maharashtra state IAPSM for 2015 and 2018. She was executive member, and Saroj Jha award for Gender 2009 in National IAPMC. With this, madam has got 22 paper publications in national and international journal. With this, madam, I request you to kindly share your screen and proceed with your presentation. All to you, madam.
Thank you so much. I hope I'm audible.
Yes, madam, you are audible.
Okay. First of all, I think I should thank you, Dr. Shafi sir, for making me a part of this wonderful activity. And I must say that all the were very much interested and everyone was really enthusiastic. And I really felt nice because many of the speakers have given practical advices also. So let's begin today's session, last session. So prevention and control of hypertension. And I just want to wonder whether it is possible. Because we have seen that there are many modifiable and non-modifiable risk factors, and age is one of it. So I feel that we should really need to work hard about it. And I know that majority of you are happy to see me just because I am the last speaker, and all of us have been here online for whole of the day. And I am also that majority of the points that I was going to tell, they have already been covered. So my job now is very simple. I will just go through my slides and it will be like a revision for us. And let's see if I can give you at least one or two points which are different or quite useful for you. Just like previous speaker said that this is going to be very useful for you for dealing with your patients, because I know we have a mixed crowd and majority of you are practitioners. So again, I have kept the points which will be applicable for your practice. So before we begin, I hope you know your numbers. By numbers, I mean, when have you last checked your BP? Usually what happens is we check it once we cross 30s or 40s. Before that, very rarely we get a chance to check our blood pressure. And I think today all of us have understood that BP could start even in childhood. So every one of you, as well as every member of your family, should get their BP checked at least for the first time. And based on the readings, the next further actions can be decided. And why this is important? Because I am a public health person or preventive person. And I always tell my students that what you learn in preventive medicine is not only about practice or not only about your patients. Please, whatever I'm going to tell you, keep on noting the things for that, because you can use them in practice as well as for yourself or for your family. So, is prevention possible was my question. And if you have understood the concept of prevention completely, then your answer will be yes. Because prevention does not only mean that it will be prevention of the occurrence of the disease. We all know that various levels of preventions are there, like primordial, primary, secondary, and tertiary. And as per that, primordial prevention activities you can apply to all of your patients or specifically to the relatives, family members of the patients who you are treating. Then primary prevention will be for those in whom you have identified the risk factors and they have little bit more risk of having hypertension. And various secondary and tertiary activities like screening, treatment, and prevention of complications will be for all patients with or without complications. So let's begin with the preventive actions first, which are the major actions. And like I said, nearly everything has been already discussed. You are free to have screenshots because I have kept my PPT majoritarily pictorial so that you will have something with you which you can refer back and compare or share with your patients for easy understanding. Now, DASH diet, I have used this infographic so that you will have a visual impression about how much fruits you are supposed to eat as compared to the grains. Grains should be whole grains, right? And this is the amount of quantity of fruits. Usually we eat fruit as 1 or 2 pieces, but these are servings, 4 to 5 servings, right? Similarly, we have to cut short the dairy, and whatever dairy products we are having, they have to be low fat. So we have to control fat. And about proteins, madam has also discussed. See, the different infographic will tell you what things to eat and what things not to eat. So about some points in DASH diet, we'll see in detail. But before that, I have included this slide which will tell you the fruits which are rich in sodium. We all know that we have to curtail our intake of sodium. And this example where food which has high sodium is shown, it is important. You will see that majority of this food is healthy food. Then what to do about it? If your BP is normal, you need not worry. But if a person of hypertension has to choose the food for the day. For example, sweet potatoes is a food which is used in fasting. So a hypertensive patient should restrict or avoid eating sweet potatoes or have small portion of it, right? So in this way, this information will help you. But what is a better information? Food that is low in sodium, which the person can have as much as the even hypertensive person can have. So asparagus, strawberries, grapefruit, and shrimps, these fruits can be eaten because they have low sodium content. Immediately, when we have to increase our potassium content in DASH diet, these are the examples of food which are rich in potassium. Banana, coconut water, that everyone knows. Spinach is also there. Even potatoes have lots of potassium. And avocado, which is available in nearly every places. And mushrooms or cucumbers. These are the things which we can choose to increase our potassium intake. Now, second important point is cutting down the salt. We always advise the patient to cut down the salt, but having food which has very less salt, it becomes unpalatable. So the better practice is that avoiding all the foods where salt is high. Again, we give common advice like papads and pickles, which we usually remember. But as you can see, the WHO infographic, where they have advised to avoid majoritarily processed food and then adding salt to food, and most importantly, reading the labels. Now, we don't have this habit of reading the labels, and once you will start reading it, you will be quite surprised about it. So if we read the labels, we will know that bread or various sauce are very high in sodium. And usually we give children sandwiches or sauce to eat with chapatis and all those things. So fries and canned food, everything is high in sodium. So we have to also notice the hidden items or unknown items which are high in sodium. Now here, when we are discussing behavioral change in patients, it will be a little bit easier if they have such type of infographics with them. Now, this is a very good infographic which will help them to understand in which zone they are as per their weight. And if they will, on their own, they will understand if they are in a red zone, then proactively they will want to bring their weight to the lower side, at least to yellow side or to green side. So you yourself also can see whether in which zone you are at present. And I hope that this may have some effect on your wish to start exercising, about which madam has described various types of exercises and all. One more thing that you can do is have BMI calculators which are available, and immediately you can show your patient how to calculate BMI. And one more thing is, when a patient walks in your OPD, just notice his abdominal obesity. So that is the obesity which will lead to more risk as compared to overall obesity or which is just subcutaneous, right? So these small observations will help you identify a person in whom you want to assess the risk. Now, about exercise, keeping active is important. And if you have listened to madam's session, she has given you many examples in which one can remain active. So usually what we advise is advising 30 minutes exercise for at least 5 days a week. So that has come from a advice or a observation, evidence that at least 150 minutes a week exercise, aerobic exercise is needed, in which heart rate increases. And now it has been added that muscle strengthening activities should be done at least for 2 days. So whole week is covered now. For 5 days, half an hour activity of aerobic exercise and at least 2 days of muscle strengthening exercises, right? And apart from that, a person can choose from various ways, and resistance exercise which builds the muscles, as well as stretching exercises and balancing exercises, because one has to avoid the falls especially in old age. Now, minding the alcohol quantity. If you have listened to the previous sessions, sir has mentioned about a J curve where very less quantity is shown to be beneficial, but it could be a statistical fallacy also. But remember, you should never advise a patient to take alcohol in small quantities, because no level of alcohol is safe, because every intake of alcohol increases the risk of cancers. So you cannot decide that it could be beneficial for one disease and harmful for other disease. So if a person can stop alcohol, well and good. If he cannot stop, then we have to advise to reduce to one drink per day for women, and at least two, means minimum 2 drinks for men per day, not more than that. And if possible, stopping is the best example. And you can tell them it is based on the content of the alcohol. So stronger the liquor, lesser the quantity should be. And you can guide them towards various psychiatric institutions or centers where de-addiction is being done, because leaving addictions is very difficult, which is evident from this PPT, this slide. This is about tobacco, and we all know that quitting tobacco is very difficult. And those who are from metro cities, they are aware that in metro cities, females are also having smoking with increasing proportion. So here in this corner, they have shown a graph where smokers who attempted in the past year and smokers who were successful in the past year. As you can see, even though around 66% have attempted, only around 10% were successful. So it's very difficult to stop. So the best way to stop is before one starts. It is said that if you directly start smoking, then you will suffer and it's very hard to quit. But if you have first remove your desire for smoking, find out what is the reason you want to smoke, and then it might be possible to quit. So as a physician, simple things that you can do is systematically identify all tobacco users at every visit, then strongly urge all smokers to quit. You can have risk calculators to show them just by quitting smoking how much risk they are reducing. And then it will help you to identify the smokers who are willing to quit, and they will need support. They will do attempts. They may fail, but your positive support will help them to stop smoking, and aid the patient in quitting by having a quit plan or having pharmacological therapies or supplementary material and all, and schedule follow-up and keep in touch. And even if they fail, do not scold, just support them and praise their attempts. One more thing, that electric cigarettes that are very popular in youngsters nowadays, and they are as harmful as or more harmful than the regular smokings. So while taking history, people may say, I don't smoke BDs or cigarettes. You have to specifically ask about vaping or electric cigarettes to the patients and tell them that it is equally harmful. I think the importance of stress cannot be emphasized enough. And people have seen that as they grow in the ladder of their career, their stress increases, and because the stress increases, they land up in various episodes or diseases like hypertension. So here I have again shared you a colored diagram where activities like feelings, thoughts and thinking, physical signs and behaviors and examples are given, and this is the color coding or color triage is there. So red is the highest stress and examples are given, and all of us know that doctors have maximum stress because of various reasons. Stress could be because of family or patients or hospitals or financial or pressures from the society and so many things. So please also heal yourself, and you can use this for identifying the patient's stress, and accordingly here INH has given this way how to reduce the stress. In that, master stress is the acronym, and you can just see that these are very simple activities like healthy eating or avoiding social isolation. We have mobiles in our hand, we have accounts in social media, but it's we have seen that we have become alone. The human contact is missing. So proactively having human contact, social avoiding social isolation is very important for reducing the stress. Stay informed, but avoid being over informed or being stressed. Because of that, talk with people, be mindful, relax, play, exercise. Journaling is very helpful. When in stress, deep breathing helps. Sleep is important. Gratitude practice is very important, and contact with nature is important, as well as seeking support whenever needed from friends, family, and whenever needed, seeking from the professionals. Doctors are the worst patients, and we avoid seeking help from the professionals, psychologist or psychiatrist, even if we are suffering. So please avoid that, because the effects of hypertension and the complications are not comparable to a simple act of reducing the stress in time. And just learning by some techniques, we can reduce the stress. Even WHO has this online platform, which is WHO Stress Management. You can find it on WHO website, or some reels are there or links are there, bit.ly, and the word will give you the link. It is I think, chat bot in WhatsApp or Messenger, and by this chat bot you can have the skills to control the stress, and they have beautifully given you it is a very detailed chatbot, and you can again refer this to your patients also. Okay, so this was about the primary hypertension and the preventive activities, major preventive activities. But also know that secondary hypertension is also a major component. So as doctors, it is our duty to try to avoid the person's risk for secondary hypertension. So as a doctor, whenever you are prescribing drugs like NSAIDs or COPs, just have a thought that what is the risk score of that person for hypertension, and prescribe accordingly. Screen for kidney diseases. Obstructive sleep apnea has already been mentioned and discussed, and it is really important because reducing in oxygen level will lead heart to pump more and increase the pressure. So it's a very simple way in which you can screen and correct it. Many ENT people will have some corrective surgeries also for this. So recreational drug use, which is increasing in younger generation, so it will lead to a epidemic in future years. Renal vascular diseases and tobacco use goes hand in hand. Thyroid diseases are sometimes missed out, so having thyroid profile will also help. And lipid dysfunction, we have to correct that so that to avoid the further complications. So don't forget these things. Then we come to the next part, that is what we can do after diagnosis in prevention. Drug adherence is the most important thing. We all have read about the rule of halves, and in I think second session we have also seen that many people are undertreated. So drugs means the irony about hypertension is that it is a quite simple disease. We know everything about the disease. We have the drugs, but the only problem is that patients are not taking the drugs. Again, one of the previous speakers have mentioned about influenced by the other pathies. So you have to discuss with the patient, ensure that the patient is taking the drugs or following your advice. So talking with hypertensive patient, discussing their problems and trying to find out the solutions is very important. Government has come up with various hypertension protocols, and in that monthly follow-ups in the initial days, starting with one drug, increasing the dose, and then adding second drug. In that way, very systematically, they have given the information. And if it is not solved, then discussing with the patient whether adherence is good or not, it is there. So here are a few tips in which you can improve compliance of any of your patients, not only hypertensive patient. The first one is therapeutic patient education, where you discuss with or ensure that they have understood and solve their queries or answer their questions or doubts. Simplified treatment regimens, where either once a daily or combined agent, combined tablets are given. and you help them to remember how to remember to take the drugs, because taking drugs is not easy. All of us have missed antibiotics one or the other times. So lifelong treatments are very difficult. So support patients in that. Minimize the cost as much as possible. Then help the patients to have reminder programs or reminder plans or apps, or nowadays some such type of drug containers are there which will help them to understand whether they have taken drugs or not. Then early follow-ups or short-term treatment goals, or showing them that see your hypertension now has reduced because of the treatment, and praising their efforts, all will go. And maximize the placebo effects and minimize the nocebo effects, because patient already has some beliefs about side effects and they will feel that they are having the side effects. So you have to discuss all those. Regular follow-up importance cannot be emphasized, because in hypertension, because it is always changing, there might be chance that once stress reduces, once their weight reduces, once they start exercising, they modify the modifiable risk factors, there is a chance that their BP will go down with your dose. So you have to always see whether control is correct or not, or whether it is leading to lower blood pressure. So in that way, monitoring blood pressure is very important in each visits. As interns, what we have done is we have just written 120/80 for nearly every patient. But as practitioners, you should actually note, and again, I think one of the speakers have given you practical ideas about which BP machine to use and how to note and all those things. So regular screening about all possible complications, all the investigations, and again, timely referrals if you have any doubts, and collaborating with your colleagues is very important. Patients should be told about the warning signs, because those are the people who will neglect their warning signs. So they should know the warning signs like shortness of breath or severe headache, chest pain, blurry vision, dizziness, nosebleeds, or heart palpitations. So all these may indicate either BP is high or some complication is occurring, and they should know what to do, how to reach hospital at the fastest. Or sometimes like chest pain, they should know what to do, have some aspirin immediately, or some simple advice like this. I cannot again stress the importance of self-care. JNC 7 has recommended that people should engage in the 6 self-care activities. So hypertension management is incomplete if you do not take the patient on board, and not only the patient, but even the family on board, because diet changes and all these things are not possible without the support of the family. So adherence of to the antihypertensive medication is the patient's duty. Following the DASH diet, engaging in activities, physical activities, stopping or reducing tobacco exposure, weight management, and reducing the alcohol consumption. And these are the same activities which will lead to prevention of hypertension also. So you can discuss these things with your kids, with your youngsters, with young people, and even with older people. So that they will follow these things to prevent hypertension as well as for control hypertension. Now, what is government doing in all these things? So in short, we will just have an idea what is happening. We all know that for prevention, we can have population-based strategy or high-risk-based strategy. Government has a national health program, and now the program is, now the name has been changed, but the program is there since 2010, National Program for Control of Prevention of Non-Communicable Diseases. So we have clubbed majority non-communicable diseases together. Since 2017, a population-based screening was going on for 5 conditions: hypertension, diabetes, CA breast, CA cervix, and CA oral cavity. So these 5 conditions were being screened because it's very easy to screen, and the data was available with the ASHA workers and all, which patient have diabetes in their community and all. Government has started having CHOs, that is community-based officers, as sub-center, so that rural people will have some medical care immediately by a trained person who could be a doctor from allopathy or a trained nurse with additional training. We all are having now ABHA, Ayushman Bharat health accounts, where all our health records will be kept together, so that even if a person visits some other hospital in an emergency, all his previous records, all his history will be correctly available if it is there in Ayushman Bharat health account. So linkage is possible. The government has also included other NCDs, priority NCDs like COPD, asthma, CKD, which again leads to hypertension, and NAFLD, which again is a major health problem but neglected, which is non-alcoholic failure of liver, right? Then CBSE is community-based assessment checklist, which gives uniformity to the assessment of the risk of a person. I am going to show you that so that you can use it in your clinics. And various BCC wellness activities are going on, like Fit India and Eat Right movements. And most importantly, we have had India Hypertension Control Initiative, which linked all the information and provided uniform treatment options for the hypertensive patients, and it's already going on by the government. So this is the CBSE that I mentioned, that is community-based assessment card, in which these 6 points are noted, and this is very easy. Immediately you can do. You can do an assessment for yourself also. And if you see that once you cross 50 years of age, and if you are having a sedentary lifestyle as a doctor, because many doctors have sedentary lifestyle because of lack of time or lack of opportunities or busyness in the work, then immediately you are at 3. And if you have a family history, then you already have crossed 4. So we have to focus on the 4 preventable activities or modifiable factors, that is tobacco, alcohol, weight, and that is mainly waist measure. For hypertension, more the risk, more proactive control is needed. And lastly, what is the future?
It will be very kind to conclude.
Yeah.
It will be very kind to conclude, madam, in some
Yeah,
minutes.
this is last.
Okay,
The future,
okay.
what is the future?